Ikut di organs from prostate up to all the genital parts, okay, the penis and all these things, you will need to have the DST, right? Without DST, you cannot have these organs. So, just give me a second. Yeah. So without the DST, you cannot have these organs, and as a result, you will end up not having these organs, of course. So you will have no organs at all in the outside. It will be like a female having a female organs. Okay. So it will be a male having the outer female development, right?
Right.
And when you look inside, you won't find any of male as well as the female structures at all. If you got a mutation in the 5-alpha reductase, okay, then you cannot convert the androgens into the dihydrotestosterone. As a result, it would be a male who's having a normal gonads, having a normal internal genital structures, but the external genitals are of female. Okay, because by default, again, this sinus will again form the female structures. If the dihydrotestosterone is available, then only it will form the male structures. Okay.
Yeah.
So with these things in mind, let's discuss what structures this paramesonephric duct form. All the structures after the ovary, okay, up to the upper vagina. That means the fallopian tube, uterus, cervix, and upper vagina. Okay, these parts are formed by the Mullerian duct in the females. Okay, the fallopian tube, uterus, cervix, and the upper part of vagina. These are all formed by the Mullerian duct. In the male, you have a remnant of these duct known as the appendix testis. Okay. Similarly, the Wolffian duct, it forms all the structures after the testis. Okay. So the seminal vesicles, epididymis, ejaculated duct, and the ductus deferens. If you go in an order, you will find first the epididymis, then you have the ductus deferens, then you have the seminal vesicles. At the end, you have the this ejaculated duct. These all structures are formed by the Wolffian duct. Okay, so going in order, you will find first the epididymis, then you have the vas deferens or the ductus deferens, then you have the seminal vesicles, and finally you have the ejaculated duct. So that part is formed by the Wolffian duct. In the female, this remnant is known as the Gartner's duct. Okay, now you have a disorder, okay, which and where you have the Mullerian agenesis. And I told you, if you got a Mullerian agenesis, then you cannot have the formation of female internal organs, right? All these structures of male organ, all the structures of this female organ will not form, right?
Yes.
So it will be a patient who's having a normal ovary. If she's having a normal ovary, then tell me about the hormone status. It would be normal, right?
Yes.
So she's having a normal androgen level, she's having a normal estrogen level. So all these secondary sexual characters will be normal.
Yes.
Right? But she will lacking all the internal female genital structures, and she will end up having the vaginal pouch. Okay, the vagina is not connected to the internal structure, so she will have this vagina which will be ending in a pouch. So she will be having a history of primary amenorrhea. Okay.
Yeah.
Yes.
So a primary amenorrhea will be present because of lack of the uterine development. Okay, female will have all the secondary sexual characteristics. Okay, and no male characteristic will be present because normal hairs will be and normal hormones will be there, but she will be having a vagina which will be ending in a pouch. So whenever you see this kind of examination in a vineyard, you will always think about this Mullerian agenesis. Okay.
Yeah.
And please note that the 50% of these anomalies are also present with the renal agenesis. So whenever you encounter a patient having this kind of a Mullerian agenesis, they will always give you a history of unilateral this renal agenesis also. Okay. Yeah.
Yes.
Okay, so like I told you, initially you have the undifferentiated gonads. Okay, then if the SRY region is present, you will have a male development. If the SRY is not present, that means no Y chromosome. You will have a by default female development. Okay, you will have the ovaries, and the ovaries will release the estradiol. Okay, now the development of this Mullerian hormone, this Mullerian duct, it does not require anything. So by default, if it do not get suppressed, it will form all the internal female genitalia, right? That include the fallopian tube, uterus, cervix, and the proximal vagina. Ovaries will release the estradiol, and that will help forming the external female genitalia, that means clitoris, labia, and all this distal vagina part, right? So, like I told you, if you got agenesis of this Mullerian duct, you won't have any internal genitalia, but you will have a normal external genitalia, right? The clitoris will be there, labia will be there, and the distal vagina is already present. It's only present, which is not connecting to any of these internal structures, right?
Yes.
And now, if this Y chromosome is there, then you will have a SRY region that will secrete some hormones or something that will convert all these gonads into the testes. Testis has two cells, Sertoli cells and the Leydig cells. Sertoli cells will release the Mullerian inhibitory factors that will cause a suppression of this paramesomorphic duct. So this thing can only be suppressed. It does not need any induction, okay? But it does require the suppression by the MIF. If the MIF is not present, somehow you got a mutated Sertoli cells. In that case, this MIF cannot suppress this Mullerian duct, and you will end up having both the male as well as the female internal genitalia, right?
Yes.
Now you have the Leydig cells that will secrete testosterone, and the testosterone will stimulate the Wolffian duct. Now these Wolffian duct need the stimulation. So paramesomorphic duct needs the inhibition, and the Wolffian duct needs the stimulation. So testosterone will stimulate it, secreting the hormone. It will have a development of this Wolffian duct into the all the structures, the ductus this epididymis first, then you have the vas deferens, then the seminal vesicles, and finally it forms the ejaculated duct. You will have the 5 alpha reductase that will convert the testosterone into the dihydrotestosterone. Okay, with that you will have the external male genitalia development that include the penis, scrotum, and the prostate glands. So if you got a deficiency, or you can say a mutation in the 5 alpha reductase, in that case you cannot form the penis, scrotum, and prostate, and by default you will have the formation of vagina outside, right? Or you can say undifferentiated kind of these things will be there, right?
Yes.
So I hope you got up this picture very much clear now.
I have one question.
Yes.
The external male genitalia and external female genitalia, they are both derived from the urogenital sinus.
Yes.
Okay. Yeah. That's
By default, this sinus will form the female structures if
right.
nothing is there to suppress it. If the
Yeah.
testosterone or dihydrotestosterone were there to suppress it, then only you can have a male development.
Okay. Yeah. Thank you.
So like I told you, 3-4 things you need to remember. One is the SRY gene, second is the MIF, and third is the androgens. Okay, if any of these things become deficient, you will end up having the female development instead of male through that structure which is required, right?
Yeah.
Yes.
So all of these things we have discussed here already. If you got absence of the Sertoli cells, then you cannot have the Mullerian inhibitory factor. You will end up having both female as well as male internal genitals. If you got a deficiency of 5 alpha reductase, you will have an ambiguous external genitalia, or you can have a female development type. No male development externally will be there. Now, what happens is actually in case of this 5 alpha reductase deficiency, see, it is a deficiency. So whenever you got a high amount of dihydrotestosterone, then only you can have this activation of the remaining receptors or these enzymes, right? See, let's suppose initially you're having, because of the deficiency, you're only having 100 of these enzymes working. Okay. Now the all enzymes having a potential, a point which is called you call it a limitation factor of them, right? A saturation point they have, right?
Yes.
Yes.
So let us suppose initially you are only having the 100 hormones, okay, for the DST, and this 100 hormones, the 100 testosterones will be acting on this enzyme to be converting into a DST, okay?
Yes.
So a deficiency is there. What happens in the puberty? Instead of 100 testosterone, now you got 1,000 of testosterone, right? When the
Yeah.
patient hits puberty, you will get 1,000 of these testosterones, and all of them are stimulating these enzymes to be getting converted into a DST. So the remaining of the enzymes will be stimulated by these testosterones in the puberty.
Yeah.
So in the puberty only, you can have a sufficient conversion of this testosterone into the dihydrotestosterone, and at that point, you will be able to know that your baby was a male baby, not a female baby. Okay.
Yeah.
So
Okay.
they are the males which were raised as a female up to the puberty, but after the puberty, their parents realize that they're actually male, not a female. Okay.
Yes.
Okay.
So do remember this fact about the 5-alpha reductase deficiency. If it is a complete inhibition or a complete absence of these enzymes, then you can never know if it was a female, right?
Yeah.
Yes.
So please note, whenever you encounter a patient who were raised as a female, but now in the puberty, she's getting all the characteristics of the male, okay? And they will think that it could be a case of the realization, they will think about it, right? But when you did their examination, you check their chromosome levels, you will find that XY is present. And that's how you know that it will be the patient having a 5-alpha reductase deficiency, right?
Yes.
So that was about all these structures on this page. Any doubt, please ask.
Yeah, I had one question.
Yes.
The Mullerian agenesis, what triggers the Mullerian agenesis?
The MIF, Muller inhibitory factor. Oh, this disease you're asking.
Yes.
Oh, it could be due to any mutation or something. It could be anything that triggers, right? Not a specific cause. It could be a genetic cause also. It could be due to a mutation. It could be happen
Okay.
due to any external
Category.
damage. Or,
Okay.
yeah.
I understand. Thank you.
Any more doubt?
No, thank you.
Okay.
No, thank
So
you.
that's about the genital embryology. Then let's discuss. You have the formation of the Mullerian ducts. You have two Mullerian ducts at each side. Okay, and these Mullerian ducts need to fuse in the midline to form a normal uterus, cervix, and vagina, right? And this is
Yes.
the normal type of thing you will get. If you got a partial fusion or no fusion at all, then you can end up having all these Mullerian duct anomalies. Okay, the one is the septate uterus. In that case, you will have a normal fusion of both side Mullerian ducts. Okay, then after the fusion, you have a septal formation. Now the septa need to be regressed in order to get a normal cavity, right?
Yeah.
Yes.
If this septa does not regress, in that case, you will end up having a septate uterus. So incomplete resorption of the septum will lead to a septate uterus. Okay, now as you can see, because this part is it's taking a lot of space of the uterus, so the patient will always have a history of recurrent pregnancy loss or miscarriages, or they will have a decreased fertility. So I told you initially that whenever you encounter a patient having a recurrent pregnancy losses, you will think about 3-4 causes only. And does anyone remember all these causes?
Can you repeat the question?
Phospholipid syndrome,
Yeah, antiphospholipid antibody syndrome, one.
Mullerian anomalies,
Second,
um, coagulopathies,
what?
coagulopathies,
Yeah, the coagulopathies. 3. Robertsonian translocations, remember?
what's that, please?
Robertsonian translocation we have discussed in the biochemistry, the chromosome number 13, 14, 21, 22,
Okay.
21, 22, 13, 14, right?
I didn't remember, but also okay.
Okay, you can go back to the biochemistry and look under the last page. I think it was for the biochemistry. In the genetics part, you will see a heading saying all these translocations, right? Where you see all these Robertsonian chromosomes, or you can say the acrocentral chromosomes. You heard about it, right? Acrocentral chromosomes. Number 21, 22, 23, 14, and 15. These 5 chromosomes are the acrocentral chromosomes where you can have a translocation kind of defect. And that can lead to, again, the recurrent pregnancy losses. So the acrocentric chromosomes or this proportional translocation. Second thing is the coagulopathies. Third thing is the antiphospholipid antibody syndrome. The fourth one is the Mullerian duct anomalies. These patients will always present you with a recurrent pregnancy loss. Now, once you do, in order to diagnose this condition, you need to do the histosalpingiogram, where you inject a dye in the vagina, okay, and then you visualize this dye with the help of X-ray. Now, for a normal dye, okay, you will see all the structures which are present. Okay, you will see the vagina, you will see the uterus, you will see the fallopian tubes, as you can see, and then you will have the spillage of the contrast, because you know that these fallopian tubes are open, right? And then you have the vagina, and then you have the ovaries here, right?
Yeah.
So because these ducts are open, you will have a spillage of contrast here, which you can see. If you do not see any spillage of the contrast, that means there is some kind of a blockage in the fallopian tube. If you cannot visualize the fallopian tube at all, that means a complete blockage at the very initial part of the fallopian tube is there. Okay, so this spillage is always normal. If you do not visualize the spillage, that means there is a blockage, and that is causing an infertility to the female. Okay.
Yes.
Now, in a patient with septate uterus, you can clearly visible this kind of a septa, right? Because at that part, the dye will not go there because a septa is present. So this kind of a structure will be present. Okay.
Yes.
So this is a histosalpingogram of a septate patient, a septate uterus patient. Okay. Now, just note for now. Then you have the bicornuate this uterus, in which you have the incomplete fusion of the Mullerian ducts. And as a result, you will end up having this kind of a structure. Okay. Now, when you do the histosalpingogram of a septate patient or a bicornuate patient, it will look very much similar, right? You will think that it could be a septa also, right?
Yeah.
Yes.
So how we differentiate between a septate uterus and a bicornuate uterus? It would be done with the help of MRI. See, in the septate uterus, you're having a normal fundus, right? As you can see, a fundus is normal. It's just inside the fundus, you're having a septa because the fusion was absolutely normal, right?
Yes.
See, in case of your bicornuate uterus, you will have an indentation in the septa, in this fundus part, right? Because the fusion is not there at all. Yes. So when you do the MRI, okay, if you see a normal fundus, that means it could be a case of septate uterus. So abnormal histosalpingogram showing like this with a normal MRI, okay, you will think about the septate uterus. Abnormal this histosalpingogram with the abnormal contour of this fundus or abnormal shape of this fundus, you will think about the bicornuate uterus. Okay.
Okay.
So you always need to perform two tests whenever you see a patient having a septate kind of uterus. One is the histosalpingogram and second is the MRI of the patient. On the histosalpingogram, you will see that patient is having a septate thing. And now you're not sure, so you need to do the MRI of the patient to check for the fundus contour. If the contour is all normal, that means it is a case of septate. If the contour is abnormal, that means it is a case of bicornuate uterus. Then you have the uterine didelphus, where you have a complete failure of fusion. In that case, you will have two different internal vagina, two different cervix, and two different uterus. And you will see it like that. Okay? Two different everything. Is that okay?
Yeah.
So a double cervix, double uterus, and double vagina will be C. And the pregnancy is possible at one side, right? You can see there's no obstruction. So pregnancy is kind of possible in these patients. While in case of septate and bicornuate, you can have a recurrent pregnancy losses also. Okay.
Yeah, those pictures are histosalpingo or MRI.
These are the histosalpingogram. I told you can visualize the septas also, only not the contour, right? MRI will be very much clear. It will be showing all these structures in the vagina and all these structures in the uterus completely, right? For the histosalpingogram, you will first inject a dye, a contrast through the vagina, okay, and then you will perform the X-ray of the patient the pelvis X-ray, and the pelvis X-ray, you will see these kind of things. Okay, you will see all the pathways where all the contrast is going.
Okay.
Okay, that's how it is done. So, any doubt? And I told you, whenever you have any Mullerian duct anomaly, you will always have the renal anomalies also, right? Like the renal agenesis. So these patients, mostly they will also have the renal agenesis also. Okay. Yeah. Now, any doubt, please ask.
No, that's okay.
No, thank you.
Okay, so we have discussed all these structures which are forming with the Mullerian ducts and the Wolffian duct, and now discuss about the urogenital sinus. Okay, now this sinus has many parts. First is the genital tubercle. Okay, second, again it is a sinus. Okay, third you have the urogenital folds, and fourth you have the labioscrotal swelling. Okay, the function of the genital tubercles is to either form, in male, it can form the glans penis and the corpora cavernosum and spongiosum, that means slenders. Okay, in the females, it will form the clitoris and the vestibular bulbs. Okay, so when the estrogen is available, you will have the formation of clitoris and the bulbs in the female. If the dihydrotestosterone is available, then these tubercles will form the penis and the corpora spongiosum and cavernosum. Corpus spongiosum cavernosum. Okay, as you can see, this is a this tubercle. Okay, then you have the this sinus. As you can see, central part is the sinus. Surrounding the sinus, you have the fold. Surrounding the fold, you are having the swelling. So tubercle, sinus, fold, swelling. These four structures will develop either into the male part or into the female part. The tubercle, it forming the penis and the slenders. Okay, that means and then in females, it will be forming the clitoris and the vestibular bulbs. Then you have the sinus. Okay, and the sinus in the male, it forms the glands, which are the bulbourethral glands and the prostate glands. In the female, it forms the Bartholin glands and the urethral glands and the paraurethral glands. Okay, so in the females, Bartholin, urethral, and the paraurethral glands. In the male, it will be the bulbourethral gland and the prostate glands. Is that okay?
Yes.
Yeah, these are the sinus. Then you have the folds. Okay, and the folds in the male, they develop into the this ventral shaft of the penis. Okay, this you can see the shaft of the penis. It is formed by these folds. In the females, we are having the formation of labia minora with that. Okay, and from the swelling, in the males, you are having the formation of scrotum. In the females, you are having the formation of labia majora. So as you can see, all of these structures are the analog of all of these structures, right?
Yes.
So step one can ask you what is the female analog of glans penis. You will always answer the clitoris, corpora cavernosum and spongiosum. It has a bulbs. The bulbourethral glands, you will have a Bartholin, BB, same. The Bartholin and the bulbourethral. For the prostate, you will be having a urethral and the paraurethral glands. For the shaft of penis, labia minora. For the scrotum, it will be labia majora. Okay. Remember about these four structures: the tubercle, sinus, fold, and swelling. Okay.
Yes.
Now, any doubt, please ask.
No, thank you.
So that's everything on this page. If there's any doubt, please ask.
No,
No,
thank you.
Now you have the congenital penile anomalies. Okay. The one is the hypospadias, and second is the epispadias. As the name suggests, in the hypo, you're having the opening of the urethra in the ventral side or the inferior surface. Okay. In the epispadias, you're having the opening of the urethra into the upper surface or the dorsal surface of the penis. Okay. Hypospadias occur whenever you have a failure of the urethral folds to close. Okay. Whenever these folds are not closed, and for that you of course need the dihydrotestosterone, right?
Yes.
If you got a deficiency of this dihydrotestosterone, you will have improper closure of these folds, and you can end up having the hypospadias. Okay, if you got an improper position of this genital tubercle, okay, and I told you this tubercle is forming,
Glans, penis, and the cylinders.
yeah, the penis and the cylinders, right? You can end up having a opening of this urethra on the upper surface of the penis or the dorsal surface of the penis. Now, because you're having hypospadias due to the deficiency of dihydrotestosterone, they will always associate it with other defects also, right? Patient can have a cryptorchidism also. Okay, patient can have a upward or a downward bending of the penis also. It can happen with the inguinal hernia also. And in the inguinal hernia, I told you, you will have an improper closing of
Processus vaginalis.
yeah, the processus vaginalis, right? So all the structures which are visible on the outside of a male part, they will be, and they will not form, right? You will have an improper development of the prostate gland, you will have the improper development of the penis, as you can see, you will have the improper development of the scrotum, you will have the cryptorchidism in that case. So they're always associated with the other symptoms also, which are all associated with the deficiency of 5-alpha reductase. Now you have the epispadias, where you have the improper position of the genital tubercle. And please note, this condition is always associated with the excess trophy of the bladder. Okay, you will have the absence of skin over the bladder, and as a result, you can see the bladder with the naked eyes. Okay, the bladder is open and it is exposed in the patient. Okay, and does anyone remember about a pathology with the spinal cord, the similar pathology with the spinal cord? And where you can see that this is spinal cord very easily from your eyes.
Myelomeningocele.
Not the myelomeningocele.
Ano ba ito?
Myelocele.
Like,
No,
Tinea tarda?
no. Myeloschisis. Right? In the myeloschisis, you have no skin, no tissue, no bone covering your spinal cord. So your spinal cord is exposed and it is open, right? Myeloschisis.
Yes.
It's like
In case of,
gastroschisis.
yeah,
I say just like gastroschisis too.
yeah. In case of gastroschisis also, you will be having these exposures of your GI tract parts, right? Because the abdominal skin is not present. So schisis, thing to remember. And similar in case of excess trophy of the bladder, you're having the absence of skin and other tissue covering the bladder. So as a result, you will have an open and exposed bladder also. Okay. So any doubt about these disorders?
No, thank you.
Okay. Then you're having the descent of the testes and the ovaries. And I told you these structures are formed in the abdomen. Testes need to descend into the scrotum, into the pelvis part, right? It can happen with these 2-3 structures. One is the gubernaculum, and these are the bands of the fibrous tissue. Okay, and they anchors the testis with the scrotum. If I draw this, if this is your scrotum, this is a testis. Okay, you have the gubernaculum anchoring the testis with the scrotum, right? So as you can see, if the gubernaculums are not there, then you will have a mobile testis inside the scrotum.
Yes.
And now this testis can be rotated.
Yeah.
And what you can end up having a testicular torsion, right?
Yes.
So if the patient having any improper type of gubernaculum or the gubernaculum is absent, in that case, they will have a recurrent episodes of testicular torsion, okay?
Yes.
Now, second thing is the processus vaginalis, which is basically a outpouching, or you can say the evagination of the peritoneum. It is basically a outpouching of the peritoneum that, because that this scrotums, these testes are formed in the abdomen, okay? And along with the other structures also in the GI tract. So when they descend, some other structures like the peritoneum also come with them. Okay, so the evagination of this peritoneum covering the testes is known as the processus vaginalis. During the birth, okay, in the internuterine part, okay, these processes vaginalis need to be obliterated. And when they obliterate it, they will form a layer which is known as the tunica vaginalis. So if the obliteration does not occur, then you will have a persistent connection of this peritoneum with the GI tract also, all the intestines, right? You will have the intestines here. And because the intestines are also covering with the peritoneum, you will have and you will end up having a connection between the scrotum and the abdomen, right?
Yes.
So now this intestine can easily be herniated through this peritoneum, right? And you can have a inguinal hernia because of that. Okay.
Yes.
If not the inguinal hernia, then this layer can be filled with the fluid and you can end up having a hydrocele also. So two things with the similar pathologies. One is the inguinal hernia and second is the hydrocele. They both have a similar pathology where you have the incomplete obliteration of the processus vaginalis. Okay.
Yeah.
Okay. Yes.
So that's about the descent of testis. And doubt, please ask.
No, thank you.
No, thank you.
Okay, now you have the anatomy. We are done with the embryology completely. Now start the anatomy. Venous drainage we have discussed already. On the right side of the testis, you have the venous drainage directly into the inferior vena cava. But on the left side, you have the drainage into the renal vein first. And then from the renal vein, you can have a drainage into the inferior vena cava. So any tumor or any pathology which is blocking a left renal vein, you can end up having a varicocele also, left varicocele specifically, right?
Yes.
Yes.
And if the pathology is involving the inferior vena cava, then you can have a bilateral varicocele also.
Yes.
Okay, now second, you have the lymphatic drainage. We have discussed that already. Okay, in the ovaries and the testis, you have the para-aortic lymph nodes. And in the scrotum, does anyone remember where does the this drainage of the scrotum goes? Lymph drainage of the scrotum?
Iliac lymph node or inguinal.
And which one?
Inguinal.
Yeah, inguinal. External inguinal, and then from external inguinal into the internal inguinal, right? Okay. So scrotum first goes into the external inguinal and then into the internal inguinal. What about the penis?
It's right down the deep inguinal node.
They go into the deep inguinal lymph nodes directly bypassing the superficial inguinal lymph nodes. Okay.
Can you repeat that?
Yeah.
Can you repeat that?
See, the penis, I told you that all of the structures which are visible below the umbilicus, they will always go first into the superficial inguinal lymph node, right?
Yes.
Then the superficial inguinal lymph nodes will go into the deep inguinal lymph nodes. There are 2-3 exceptions. The first one is the penis. It directly bypasses the superficial inguinal lymph nodes and enters and drain into the deep inguinal lymph nodes. Okay. The first. Second, you have the popliteal lymph nodes from the posterior and lateral part of your leg, remember?
Yeah.
Yes.
These popliteal lymph nodes, they directly drain into the deep inguinal lymph nodes bypassing the superficial inguinal lymph nodes. Okay, so these two structures, they directly drain into the deep inguinal lymph nodes, while all the structures which you can see after the umbilicus, the skin and other structures, they will always drain first into the superficial inguinal lymph nodes. Is that okay?
Yes.
Then as you go from superficial to deep structures in the genitals, okay, you will have the drainage of this lymph from deep inguinal lymph nodes to the this external iliac lymph nodes or the interiliac lymph nodes. Okay, for example, the distal vagina, which is visible again, vulva, scrotum, distal anus below the pectinate line. These all structures, they're superficial, and that's why they always go into the superficial inguinal lymph nodes. Okay, the prostate, cervix, the outer cervix, I must say. Okay, the corpus cavernosum, proximal part of the vagina. Okay, that means a deep vagina, they will go into the internal iliac lymph nodes. Okay, then you have more deeper structures like the body of the uterus, the upper part of the cervix, and the superior part of the bladder. They will always go into the external iliac lymph nodes. Like I told you, go from superficial to deep structures. You will have the superficial inguinal lymph nodes to the external iliac lymph nodes. And finally, you have the para-aortic lymph nodes, where the uterus, okay, the upper part of the uterus, the dome of the uterus, ovaries, testes, kidneys, they will drain into the para-aortic lymph nodes, okay?
Okay, I actually had one more question. What's the
Yes.
difference between the scrotum and the testes?
The scrotum is a sac, and where the testis is located.
Okay, so the scrotum is the outside part and it
Yeah,
has a
you have the scrotum, which is kind of a skin thing. Okay, inside this scrotum, you have the testes. Okay.
yeah. And they have
That's-
different
Yeah,
lymph nodes? Yes.
yeah, of course. As this scrotum, it will go into the superficial inguinal lymph nodes, but the
Mhm.
testes, they directly go into the para-aortic lymph nodes, right?
Okay, yeah, that makes sense. Thank you.
Okay. So that's about the drainage of the gonads, the venous and the lymphatic drainage. Blood supply, you guys already know. You have the gonadal arteries, and they both are the branch of abdominal aorta descending downwards, right? Yeah.
I have a question.
Yes.
Excuse me. Yeah, I want to know, like, if there is some tumor which is compressing or something obliterating the IVC below the this renal artery or renal vein, then how
Yes.
that can cause this increased pressure of this testes and cause the varicocele or whatever.
Below the renal vein,
Yeah, just now you.
then you won't have. Then you won't have. See,
Yeah,
if you got a blockage at the level of renal vein or after the renal vein, then only you can have a bilateral swelling.
after means above.
Yeah,
Oh, yeah,
above,
yeah,
above or at the level of the veins.
yeah,
Okay. Yes, because above this level you will have a normal drainage, right?
yeah,
So it won't affect the testis at all.
yeah. That's what I'm thinking. Okay, thank you.
Sure. So any more doubt on this anatomy or this disorders?
No, thank you.
Okay, so now you're having a female reproductive anatomy. Okay, for that you need to remember some ligaments. Okay, these are the important ligaments that you must remember their function. Okay, the first one you have is the infundibulopelvic ligament or the suspensory ligaments. Okay, you guys can see this is a ovary, this is a fallopian tube, uterus, cervix, and the vagina. As you can see, they all have a different blood supply. Ovaries, they are supplied by the ovarian vessels. The uterus and the cervix are supplied by the uterine or these vessels, and the vagina is supplied by the vaginal artery. As you can see, an anastomotic channel is exists between the ovarian vessels and the uterine vessels. Whenever you got a blockage in the ovarian vessels, the uterine vessels will supply them. Whenever you got a blockage in the uterine vessels, the ovarian vessels will supply them. Okay.
Yes.
And the first one is the infundibulopelvic ligament. This ligament that you can see here, this is the infundibulopelvic ligament or the suspensory ligament. Function of this ligament is to connect this ovary with the lateral wall of the pelvis. Okay, so basically it helps supporting the ovary and keep them stabilized with the lateral wall of the pelvis. It contains all these ovarian vessels that you can see. They are all contained in the infundibulopelvic ligament. Okay, so whenever you got a damage of this infundibulopelvic ligament, and that actually happens whenever you want to do the oophorectomy, that means if you want to remove the ovaries, then you must need to disconnect the ovaries with the pelvis wall, right?
Yes.
In order to do so, you need to remove, you need to cut this suspensory ligament while ligating it, while cutting it. Okay, because the ovarian vessels are lie very close to this structure, you can have a damage of the ovarian vessels, right?
Yes.
And that can lead to a life-threatening hemorrhage also. So you need to be very careful while performing the oophorectomy. You always need to ligate these vessels first because of a chance of hemorrhage. The second one is the cardinal or the transverse ligament. Similar to that of infundibulopelvic ligament, the function of cardinal ligament is to connect the uterus with the lateral wall, or the cervix with the lateral wall. Okay, not the uterus, but the cervix with the lateral wall of the pelvis. Okay, it contains all the uterine vessels. So whenever you perform this hysterectomy, that means a removal of the uterus, in that case, you need to cut this ligament, right?
Yeah.
While cutting this ligament, you need to always ligate all these uterine vessels because they lie very close to this structure, so they will have a risk of damage. So in the hysterectomy, you can have a damage of the uterine vessels, you can have a life-threatening hemorrhage. In the oophorectomy, you can have a damage of the ovarian vessels because of infundibulopelvic ligament. So you need to always ligate the ovarian vessels and the uterine vessels while performing the oophorectomy and the hysterectomy respectively, okay?
Yes.
Third one is the round ligament of the uterus. And as you can see, on this structure, as you can see, this is a round ligament of the uterus connecting the uterus with the anterior wall, or you can say the labia majora. So because this is connecting the uterus with the labia majora, this is the only structure that passes through the inguinal canal. And that is a very high yield point. This round ligament of the uterus that you can see going anteriorly coming out of this page, if you imagine 3D, okay, this structure is coming out of the page, it is connecting the uterus with the labia majora, okay, and it need to pass through the inguinal ring. So this is the only structure that passes through the inguinal canal, okay, and please note it is a derivative of the gubernaculum, okay.
Okay.
So two things about the round ligament: a derivative of the gubernaculum, and second, it passes through the inguinal canal, the only structure. The second derivative of the this gubernaculum is the ovarian ligament. The function of this ligament is to connect the ovary with the uterus. Okay, so basically on the lateral side, the ovary is stabilized with the infundibulopelvic ligament, and from the medial side, the ovary is stabilized with the ovarian ligament. Okay.
Okay.
And again, this structure is a derivative of the gubernaculum. Okay. Although this structure is a derivative of the gubernaculum, it still do not passes through the inguinal canal. Okay, the only gubernaculum derivative that passes through the inguinal canal is the round ligament. Okay.
Yeah.
Okay.
Now, finally, you have the broad ligaments, and it is kind of a folds that are covering all these ligaments. As you can see, these are all the fold-like structures covering all these ligaments respectively. Okay. Whenever you hear the word salpinx, always think about the fallopian tubes. Okay. Whenever you heard about the metrium, mesometrium, okay, endometrium, right? Think about the uterus. Is that okay?
Yes. Yes.
And whenever you hear about the varium, think about the ovaries. So salpinx word goes for the fallopian tube. Yeah, and like for example, salpingitis, remember?
Yeah.
Yes.
And where you have an inflammation of the fallopian tube. Similarly, mesometrium, you will have this uterus, and the varium goes for the ovary. So this ligament has three folds: mesosalpinx, mesometrium, and the mesovarium. The mesosalpinx, it will be covering your fallopian tube, as you can see. This is a fold, mesosalpinx. Okay. Then you have the mesometrium covering the round ligaments. Okay. And then you have the mesovarium covering the ovarian ligament. Okay. So the mesosalpinx covering the fallopian tube, as you can see. This is the mesovarium covering the ovarian ligament, and this is the the mesometrium covering the round ligament. Okay.
Yes.
And please note, this broad ligament is actually a peritoneum in the abdomen. So whenever the step one asks you what genital organs are the intraperitoneal, you will always answer the round ligaments, the ovarian ligaments, and the fallopian tube. Okay, they are the intraperitoneal structures. And as you can see, this peritoneum is covering the bladder, the dome of the bladder also, right?
Yes.
And this thing is very significant clinically. We will discuss how later in the part. Okay. Whenever you got a damage in the dome of the bladder, you will have the leakage of the urine within the peritoneum. So you will have an intraperitoneal fluid accumulation, right? So do remember this fact also. This peritoneum is also covering the upper part of the bladder also. Okay, and these three structures, they are intraperitoneal. Rest all these structures are kind of the pelvic structures or the retroperitoneal structures. Okay. So that's about all these ligaments. The last ligament that is not shown here, this is a uterosacral ligament, and it connects the uterus with the posterior side. This ligament goes posteriorly, okay, and it connects the uterus to the sacrum. Okay, the lower part of the uterus, which is near the cervix, is connected with the sacrum. Okay, you have one more ligament which is not shown here. Any doubt, please ask.
What is the origin of the uterine arteries and the vaginal arteries?
The internal iliac vessels.
Okay, thank you.
I told you have many branches like, the glutes, for example, the supragluteal artery, infragluteal artery, uterine artery, ovarian artery, right? And the pudendal artery also, I think. They're all the branches of an internal iliac vessels, okay?
Okay, thank you.
Just give me a second. Yeah. So that's everything about all these structures on this page. Now you have the adnexal torsion, that means the twisting of the ovary and the fallopian tube, and that happens around the infundibulopelvic ligament or around the ovarian ligament. Okay. Whenever you have a twisting, you will always have a compromise of these ovarian vessels. You will have a twisting of these vessels also. These vessels got blocked, right?
Yes.
Yeah.
Let me draw this. Whenever you have a twisting of the ovary like that, okay, you will have the twisting of these ligaments also, and hence these vessels also, and that will lead to a blockage in these vessels, right?
Right.
Now, because the veins are always thin-walled and the arteries are kind of muscular, you will first have a blockage in the veins. As a result, the drainage of the blood from the ovary is now stopped, okay? But you still have the perfusion of the blood via arteries, right?
Right.
Yes.
Because of that condition, you will end up having the accumulation of the blood into the ovary, and the ovary got swelled. Right?
Yes.
Yes.
Now, what happens is, as the blood is accumulating in this structure, okay, still you do not have any kind of ischemia thing because the blood is there. You won't have any ischemia right now, okay? Now, what happens because the blood drainage is now stopped, okay, and the perfusion is still continued, you will have a rise in pressure there. Because of this accumulation of blood, you will have a rise in pressure there, right?
Yes.
And whenever this pressure exceeds the pressure in this artery, you will have this blood flow stopped. You cannot have a further blood flow, right?
Right.
Yes.
At that point, you will start developing the ischemia. And because the blood is not there, you will ultimately end up having the necrosis also. Okay.
Yes.
So it will be a patient that presented with the acute pelvic pain. Adnexial mass will be there, and that mass is because of the swelling of this ovary. The patient will be having a nausea, vomiting. Okay, you do the MRI CT of the patient, you see a unilateral mass there. Okay, and when you do the removal of this these ovaries, and when you perform the oophorectomy, you will see the ovaries are filled with the blood. Okay.
Yes.
Yeah.
And because again the necrosis and this hemorrhage is there, you can also have the fever also in the patient. Okay, so that was about the adnexial torsion. So it is a twisting of the ovary and the fallopian tube around the infundibulopelvic ligament or the ovarian ligament. You will have the compression of the ovarian vessels in the infundibulopelvic ligament. You will have a blockage of the lymphatic and the venous outflow. The artery perfusion will be continued for some time, and that will end up having an ovarian edema. The complete blockage of the atrial perfusion now happens, and you will get a necrosis and the local hemorrhage. And please note, you will get a torsion only whenever you have some kind of a mass in the ovary, for example, a tumor. It could be a teratoma. It could be any ovarian tumor, a benign tumor or a malignant tumor. Okay, that makes this ovary heavy and increases the risk of the torsion of this ovary. Okay.
Yes.
Yes.
So a history of some kind of a tumor is always present, or if not, they will ask you what could be the pathology behind this rotation. So please note it is always some kind of mass. So whenever you encounter a patient having this kind of a torsion, you will first diagnose them for any kind of a cancer. You will search for the cancer, right?
Yeah.
The patient always present you with a very severe acute unilateral pelvic pain. So this pelvic pain can also mimic, because they cannot localize whether it is a pelvic pain or whether it is abdominal pain. So they can tell you that it could be a pain of appendicitis also, right? Because in the lower part of abdomen, you also have the appendicitis pain.
Yes.
Yes.
So this thing can also mimic the appendicitis. You will have, but you will have a adnexal mass along with nausea, vomiting, which is again seen in the appendicitis. You will also be having a fever, again seen in the appendicitis also. So apart from this mass, how you can differentiate this condition from the appendicitis?
Age.
Menstrual
And what? Well, the age of the patient is again very young. Both the young patients can have the appendicitis as well as this axial torsion.
menstrual bleeding.
What about menstrual bleeding?
It's been over 4 weeks.
No such kind of a history is there.
So will the
Maybe a
ultrasound?
little pain and adnexal torsion, which then gets shifted to the McBurney spine.
See, one thing is, in case of appendicitis, you will be having a shifting of the pain from the umbilical region to the McBurney spine. Remember,
Yes.
one thing is it. Other thing, the location of the torsion is very important. Okay, the location of the torsion, because you see on the right side. Just give me a second. I'm confusing whether it is the right side or left side. Just give me a second. Yeah, the right side of the torsion is more common than the left side. Okay, because on the left side you're having a rectosigmoid colon, right? If I draw this for you, this is the right side and this is the left side. Okay, now as you can see on the left side, you're having this rectosigmoid colon, right?
Yeah.
So this left side torsion is not very much common, but the right sided torsion is very much common. So whenever the torsion happens, it most commonly happens on the right side. Okay, note that fact also. So history of fever, acute nausea, vomiting, abdominal pain. It could be abdominal, it could be pelvis. If they tell you it is abdominal pain, then most chances it could be appendicitis also. For that, you need to always differentiate. If the shifting of pain history is present, then you can think about the and then you can think about the appendicitis. Okay, and yeah, history of a mass is also there. Okay, a severe this adnexial mass you can easily see on the CT MRI of the patient, right? So these things will help you differentiate between the appendicitis and the ovarian torsion. Okay,
Yeah.
so yeah, and that would be all about it.
I have a
And,
doubt.
and you can also, yeah, one more thing I want to tell you. You can also perform the ultrasound of the patient, and all the ultrasound you check for the blood entry. Okay, and when you perform this pelvic ultrasound, what you will see, you will have a decreased blood supply to the ovary. Okay, and of course, with the help of ultrasound, you can also see this kind of this adnexal mass also, right? So a decreased blood flow to the ovary on the ultrasound, and the presence of this mass on the ultrasound, you will immediately know that this patient is having a adnexal torsion. Okay. Yes. Now ask.
While there is a twisting in the ovary, right? So why can't there is a compression in the artery? Why only it's the lymphatic and the veins?
Because they are thin-walled. Arteries are muscular, right?
Oh, okay.
Yeah, they are
Okay, thank
thin-walled.
you.
These arteries, the veins are thin-walled, so they will compress first. Compression of the arteries occur, but it occurs very later. Okay.
Okay. Thank you so much.
Yeah. And I think that would be all about this adnexal torsion. And please note, it can also mimic, this ectopic pregnancy, right?
Yeah.
Because similar kind of a pain, acute severe pelvic pain can also happen in the ectopic pregnancy. So whenever you encounter a patient having this kind of acute pelvic pain with the adnexial mass, you will always need to run the beta HCG of the patient also. Okay.
Yes.
And please note, whenever you have an ectopic pregnancy, you will also have a history of vaginal bleeding, right? Because all of this blood will be going into the fallopian tube and then into the uterus, cervix, and then vagina, right? So history of bleeding from the vagina, having a beta HCG positive, think about the ectopic pregnancy. If the bleeding is not there from the vagina, just adnexial mass and a pain, you will think about the adnexial torsion. So these two things will help you differentiate between the ectopic pregnancy and the adnexial torsion, okay?
Yes.
Okay, now I told you that this, just give me a second. I told you that the ureter runs very close, or you can say are very parallel to these ligaments. Remember the ovarian vessels and the infundopelvic ligament. I told you this ureter lies are very this ureter lies very parallel to these structures. Remember
Yes.
the descent of the ureter, and I told you after that it will go down and deep dive into this cardinal ligament, right? That these uterine ligaments I told you. In the anterior side, you have the uterine ligaments. In the female, and in the males, you have the vas deferens, right?
Yes.
So see, whenever you want to perform either the oophorectomy or the hysterectomy, you need to carefully ligate these vessels, because if you ligate these vessels and you somehow got the ureter damaged, patient can have a leakage of the urine right now. Okay. So the patient will be having a flank pain, fever. Okay. The patient will be having, because of a blockage, patient will be having a distension of the proximal uterus. Hydronephrosis will be there. And if a transaction happens, okay, then it will lead to the complete leakage of the urine and the flank pain. Okay. Now, if a bilateral, and please note, for the unilateral injury, you will be having a normal micturition. If the bilateral injury occurs, that will lead to a complete anuria with a bilateral flank pain. Okay. In the unilateral injury, the creatinine levels will be normal. In the bilateral injury, you will having a rising of the creatinine level also. Okay.
Yes.
Yeah. So always note, a patient who is having a history of oophorectomy or the hysteroophorectomy, maybe she is now admitted in the hospital, and within the hospital, she started having the bilateral or unilateral flank pain with fever, okay, or having a history of anuria. So always think about the injury to the ureter, because they are the most common structures that got damaged in the oophorectomy or the hysterectomy. Okay.
Yes.
Yes.
Now, any doubt, please ask.
No, thank you.
No, thanks.
Okay, so that would be everything on this page. So let's take a short break and then move forward. Okay.
Yes. No, thank you.
Okay. So now let's discuss the histology of the female reproductive tract. Okay. So on the outermost, you have the vulva, okay, which is made up of the stratified. Please note, it is a stratified squamous epithelium. What does this stratified means? Yeah.
Multiple layers.
Yeah, multiple layers. Yes. Okay. The cells always present here, as you can see, they're always in the multiple layers. You call it a stratifications. Okay. And what does this pseudo stratification means?
Sorry, what is
Pseudo stratified. Sometimes the layers are also pseudo stratified, right? So what
it is
is this pseudo stratified?
It's a single layer, but appears like more than one layer.
Yeah, it is a single layer, but it appears to be a multiple layer, because the nuclei are not arranged in a specific level, right? Some nucleus are
Yes.
present upward, some nucleus are present downward. So it appears that this tissue is having a multiple layers, but in reality, the tissue is having only single layer. So you call it as pseudo stratification. Okay, so for the vulva, you have the stratified squamous. See, up to the external cervix, okay, all the epithelium is always stratified squamous epithelium. Okay, so that means this vulva, vagina, and the ectocervix, it's always the stratified squamous epithelium. Within the cervix, you have the transformation zone, and in this transformation zone, this stratified squamous epithelium becomes the columnar epithelium. So from the internal cervix up to the fallopian tube, all the layers are simple columnar epithelium. And now within the ovaries, you have a layer, and that is a simple cuboidal. So up to the ectocervix, stratified squamous, up to the fallopian tube, columnar epithelium, and within the ovary, it is the cuboidal epithelium. And you guys also know that this human papilloma virus can infect only the stratified squamous epithelium, right?
Yeah.
And that's why you only have the ectocervical cancers mostly. Okay, that's why you have the vaginal cancers, the vulvar cancers, and the cervical cancers that can be caused by the human papilloma virus. You cannot have any uterine cancer which is caused by the human papilloma virus, right?
Yeah.
So remember that fact also, the human papilloma virus can only affect the stratified squamous epithelium, and that means the human papilloma virus can cause any cancer from vulva up to the ectocervix. Okay, as you can see, this is the keratinized epithelium. Sorry, non-keratinized stratified squamous epithelium. As you can see, these are all the multiple layers. That similar layer you can have in the skin also, if you guys go back. But in the skin, the keratin is also present. So on the upper part, you also see this very eosinophilic structure, right?
Yeah.
There is a keratin. So this keratin is absent, as you can see. All the layers are very much similar to that of the skin also. Then this is a transformation zone. And from this zone, all the layers are of this columnar epithelium, as you can see, right?
Yeah.
So this is the femoral reproductive histology. Now, I told you also that all these structures which are formed by the Mullerian duct, they all always have the columnar epithelium, right?
Right.
So Mullerian duct always forms the columnar epithelium. So up to the upper part of the vagina, okay, or you can say the deep vagina, right? All these layers have the columnar epithelium. But within the intrauterine life, all this columnar epithelium of outer cervix, it got replaced with the stratified squamous epithelium, right? If you give the patient DES, remember?
Diethylstilbestrol.
Yeah, diethylstilbestrol. And this drug, this drug will inhibit this metaplasia or this conversion. Okay, so now whenever you give the patient DES, the conversion of this columnar epithelium into the stratified squamous epithelium, it does not occur, and as a result, you can have the columnar cancer, the adenocarcinoma of the vagina instead of the squamous cell carcinoma. Normally, you have only the squamous cell carcinoma because the vagina lined by the squamous epithelium, but in the patient who are on the DES therapy, they can have a adenocarcinoma. Okay.
Yes.
So that's about the histology. Any doubt, please ask.
Could you please once repeat it?
Yeah.
Could you please once repeat it? This.
See, all the structures, that means the fallopian tube, uterus, cervix, and the inner part of the vagina, they're formed by the Mullerian duct, right?
Yeah.
And the Mullerian duct always forms the columnar epithelium. So in the intrauterine life, up to the endovagina, this internal vagina, they all have a columnar layer. Okay. But then what happens is this columnar epithelium is got replaced by this squamous epithelium up to the ectocervix. That means the outer cervix, okay, that epithelium is got replaced by the squamous epithelium in the normal patient. In those who are on the DES therapy, this conversion does not occur, and as a result, they will end up having the columnar epithelium in the vagina. Okay.
Okay. Okay.
And as a result, they can have this adenocarcinoma of the vagina instead of the squamous cell carcinoma, right?
Yeah. Yeah. Okay. Thank you.
And you guys also know the features of the squamous cell carcinoma, I hope. what you will find on the examination of a squamous cell carcinoma?
Keratin pearls.
That is on the histology, on the examination, normal outer examination from your eyes. What you can see?
Fragile.
What thing?
Fragile tissue. So
Sorry.
gross.
Yeah,
Gross.
on the gross examination, what you will find on the cancer? How this cancer look like?
Irregular, fragile margins.
Not a very specific description actually. You're having bleeding, ulcerations are a very characteristic thing, right?
Yeah.
Ulcerations you will see.
Yeah.
Bleeding will be there, necrosis will be there, ulcers will be there, right, on the skin. And then when you take the biopsy and you visualize it in the microscope, what you will find? The keratin pulse. And that's how you confirm that the patient is having a squamous cell carcinoma. And if it is a carcinoma caused by the human papilloma virus, you also have one thing apart from that.
There is a special type of cells.
And those cells are known as
Um,
the coilocytes, right?
yes.
Okay, so these cells are also seen along with the keratin pulse, and that's how you know that this cancer, this squamous cell carcinoma, is caused by the human papilloma virus. Okay.
Yes.
So remember this fact also. Now we are done with the female reproductive tract. Now let's discuss the male reproductive tract anatomy. Okay, and so let's start with the testes. Okay, you have the testes which are present in the scrotum. I told you that they all form in the abdomen, and then from the abdomen they always descend into the scrotum. In the downward for the attachment of the testes with the scrotum, you have some ligaments, and those ligaments are known as fibers. What help the testes into attachment with the scrotum?
Vaginalis?
2 pages before we have discussed that.
The gubernaculum.
The gubernaculum, yes. Don't forget that, right? Gubernaculum anchor is the testis with the scrotum. If this gubernaculum is not there, you can have a testicular torsion, just like the agnosial torsion, right?
Yes.
Okay, so the testis, it has layers. It has 3 outer coverings. And does anyone remember the name? The outermost one?
Tunica vaginalis.
So tunica vaginalis is the outermost layer. Then the middle layer?
Tunica albuginea.
No, it is vasculosa. Okay, and the albuginea is the innermost layer. So albuginea innermost, vasculosa middle one, and this vaginalis is the outermost layer of the testis. Okay.
Okay.
Now, if you cut the testis and you see it, you will find that this testis have many septas. Okay, so within these septas you have the lumen, and in these lumens you have the seminiferous tubules. Okay, within these seminiferous tubules you have all these germ cells. In the center of the seminiferous tubules you have a lumen, okay, a duct-like thing, and from that duct, these seminiferous tubules will connect with the retitestis. Ultimately, from the retitestis, you have the origination of the epididymis. You have a head of the epididymis, you have the tail of the epididymis. And finally, from this epididymis, you have the formation of the vas deferens. So they are all the tubes, okay? And within the layer of these tubes, if I draw that, if you take a cross-section of these tubules, these seminiferous tubules, what you will see that this is kind of a layer. These are a tube-like thing. In the center, you have the lumen, right? This is a lumen. And you have many germ cells here, okay? All the Sertoli cells are present here. And the function of Sertoli cells, which we will discuss later, they form the blood-testis barrier. On the outside part of this blood-testis barrier, which is made by these Sertoli cells, on the outer side, you have all these germ cells. And on the inner side, you have all these matured cells, these sperms, okay?
Yeah.
So that is what you see on the histology. And as these sperms matures, they will go into this lumen. And from that lumen, they will go into the retitestis, then to the epididymis, and then to the vas deferens. Okay?
Yeah.
Now, this vas deferens, it enters into the abdomen, okay, loop around the urinary bladder, okay, and then you have the ureter. I told you that in the females, anterior to uterus present what structure?
Uterine artery.
Uterine artery.
The uterine artery and the cardinal ligament, right? Or the transverse ligament. In
Yes.
males, I told you anteriorly you have the vas deferens, right?
Vas deferens. Yes.
So this vas deferens will loop from anterior to posterior. On the posterior side, you have this vas deferens will meet with the seminal vesicles. And please note, almost 50 to 60% of the secretion in a semen, okay, it consists of all the secretions which are secreted by the seminal vesicles. It secretes the fructose, prostaglandins, fibrinogen, and all other things. So the major secretory pathway, this part is of the seminal vesicles. Now, when this vas deferens, when it meets with the seminal vesicle, it forms a ejaculatory duct, as you can see. And now this ejaculatory duct will combine with this urethra, right? The duct from this urinary bladder, and they will combine to form the urethra again, as you can see. And this urethra, it also contains the secretion of prostate gland. As you can see, this urethra passes through the prostate gland, right?
Yes.
Yes.
So the urethra passes through this prostate gland, and finally it enters into the penis, right? Penile shaft, as you can see, and finally it opens, right? So this is the anatomy of the male reproductive tract that you must remember. Please remember the sequence. First, you have the testes. From the testes, you have the seminal vesicles. Okay, sorry, the seminiferous tubules. The seminiferous tubules will enter into the right testis. Right testis will form the epididymis, and they will then become the vas deferens. Vas deferens that loops around the urinary bladder, it will meet with the seminal vesicles, secrete around 60% of the semen. Okay, then they meet the prostate glands, and the prostate glands will secrete the alkali secretion that will make the semen very thin, and that increases the motility of these pumps. You must remember the function of this prostate: alkaline the secretions. Okay, then again you have the bulbourethral glands that will again secrete the bicarbonate, and that will neutralize the acidity of the vagina. Okay, these are the final glands. As you can see, these are the bulbourethral glands. And does anyone remember the female analog of the bulbourethral glands?
Bartholin.
The Bartholin. Both starts with the name B. And the analog of the prostate gland? See, you can say, and you can easily see that this prostate is present around the urethra, right?
Urethral
Yes.
and paraurethral.
So periurethral glands, right?
Yes.
Yeah.
So the female analog of the prostate gland is the periurethral glands, right? Okay, so finally you become this ejaculatory duct, and this duct will enter the prostate and it becomes the urethra, right? And then it got opens in the glands penis. So we have cutted the testes, and we have seen what structures are present inside the testes. Now let's see the cross section of the penis. On the outside, you have the skin. Okay.
Sorry, please.
Then yes.
Can you repeat the things secreted from the seminal vesicle?
Sorry. Repeat again, please.
Things that secreted from seminal vesicle. What was those?
Your voice is not clear. Actually, there's a lot of background noise.
Sorry, I'm asking about the secretions of seminal vesicle.
Okay, secretions of seminal vesicles. Okay, see what happens is when these vas deferens, they meet with the seminal vesicles. Seminal vesicles will secrete this fructose, energy, prostaglandins, and the fibrinogen, and they consist of around 50 to 60% of the secretions in the semen. So the majority part is always of the seminal vesicles. Okay, and finally they enter into the prostate gland. Prostate glands will secrete the alkaline secretion that will make the semen very thin, and that increases the motility of the sperms. Finally, the sperms, the semen will meet with this gland, the bulbourethral gland, that again secretes the bicarbonate, and the function of this gland is to make this acidity of the vagina neutralize. Okay, it will neutralize the acidity of the vagina, and finally, they all will be secreted by this urethra. Okay.
Okay, thank you.
So we've discussed the cross-section of the testis before, and now let's discuss the cross-section of the penis. On the outermost side, you have the skin. Just after the skin, you have a layer that known as the dartos fascia, or the superficial fascia, of course. After superficial fascia, you have some adipose tissue layer. As you can see, this is all the fatty tissue layer. Within this fat, you have the vein known as the superficial dorsal vein. So in the after superficial fascia, you have the superficial vein. Okay. Then you have the deep fascia, which is, of course, makes sense. After superficial fascia, you have the deep fascia, and this deep fascia is known as the Buck's fascia. Okay. This fascia surrounds all the cylinders. That means the corpus, the cavernosum, and the corpus spongiosum. Okay, and it contains all the blood vessels also. After this deep fascia, you have the blood vessels, and these are the deep veins. Okay, the deep dorsal veins. You also have the dorsal artery and the dorsal nerves. Okay, finally, the innermost layer is the tunica albuginea, which is the layer that is surrounding the testis. So step 1 will ask you, what is the layer of testis, okay, that surrounds the cylinders also? So the answer is tunica albuginea. Okay, it is the and it is the innermost layer of the testis, and again the innermost layer of the penis also, right?
Yes.
So as you can see here, this is the
Continuation. It's a
yeah,
continuation of the same layer or a different one?
yeah, same layer continued.
Okay.
Okay, same layer is continued, no different layer. So as you can see, this is the cylinder in the center, and this is a yellowish layer. You can see this is the tunica albuginea. It is surrounding the corpus cavernosum, and similarly after this deep fascia, as you can see in the corpus this is spongiosum, you will have the tunica albuginea, which is the innermost layer. Okay, in the corpus cavernosum, you have the deep arteries. Okay, so a dorsal artery within just after the deep fascia. Okay, and the deep artery present after the tunica albuginea within the cylinders. Whenever this vessel dilate, you will have a blood flow from there. And as you can see, this corpus cavernosum, it consists of all these lacunas, right? These spaces are present, right? And the blood will be filled here, and you will have the erection of penis because of that. Okay. Then you have the corpus spongiosum, and it contains the urethra. The opening of the urethra is present here. Okay.
Yes. Yeah.
So this is the structure of your penis. So outermost layer is skin, then the superficial fascia, or you can say the dartos fascia, then the layer of fat that consists of the superficial vein. Okay, then after that, the deep fascia or the Buck's fascia. After that, the deep vein is present, dorsal artery is present. Then finally, you have the tunica albuginea that consists of all, that contains all the cylinders. In the cylinders, you have the deep artery. In your corpus, this cavernosum, and in the corpus spongiosum, you have the opening of urethra. So these are the layers of your penis. You do remember that. Step 1 will point at a structure, and they will ask you what structure it could be. So you must know how it looked like. Okay.
Yes.
And you must also know, along with the transportation of the sperms in this vas deferens and the epididymis, they also store the sperm. Okay, and they have a storage for around 3 months and for at least 20 ejaculations. So even if you do the the vasectomy of the patient, okay, you still can have the sperms up to 3 months and up to 20 ejaculations. Okay, so whenever you perform the vasectomy, you always advise the patient to use the contraceptives or to avoid the intercourse for up to 3 months or for up to 20 ejaculations. Okay.
What
Yes.
part is removed in vasectomy?
Yes.
In vasectomy, which part specifically is removed?
The vas deferens. You will cut the vas deferens and you will tie the vas deferens. Okay, so that the connection is disrupted. But the vas deferens, it still contains all these sperms for about 3 months. Okay.
Okay.
It just as you can see, if I draw this is a vas deferens. You will cut the vas deferens from here. Okay. And then you will
Yes.
tie it. So still you can have all these sperms stored here, right?
Okay.
And they will come up
Okay.
in the this ejaculation. Okay, so please note, step 1 will ask you after performing the vasectomy what advice you should give to the patient. So please note, you have to give them the advice to use the contraceptives for at least 3 months. Okay, for up to 20 ejaculations. Okay.
Yes.
So any doubt on this page?
No, thank you.
No.
And you guys already know the branch, this blood supply of the testis and the ovary, and that is by the abdominal aorta, right? And the blood supply of all these internal organs, like in case of my females, the uterus, it is a branch of internal iliac artery. Okay.
Yes.
So step 1 will also ask you this fact while performing this hysterectomy. Okay, or maybe let's suppose it is a case of the postpartum hemorrhage. That means a bleeding in the uterus, and the blood supply of the uterus is the uterine artery, right?
Yes.
Yeah.
In order to supply this blood, this leakage of the blood, this hemorrhage, you need to block the uterine artery. Okay, and if you block the uterine artery, then what can happen? You can have a ischemia of the uterus, right?
Yes.
Yes.
But that thing does not happen because you have an anastomotic channel between the ovarian vessels and the uterine vessels, and the ovarian vessels are now supplying the uterus. Okay.
Yes.
And they will ask you, if not the uterine artery, then what other vessel you can block? So answer is the internal iliac vessels. Okay.
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 Remember that. Now let's discuss the urethral injury. Okay. So you have the anterior urethra and you have the posterior urethra. Okay. This part that you can see, this is the anterior urethra that is present within the penis. Okay. After that, you have the posterior urethra. Now this posterior urethra has two parts. Okay. One is the membranous urethra and second is the prostatic urethra. Okay. The prostatic urethra is present within the prostate, as you can see here. Yeah. This part up to here, this is the anterior urethra. Okay. Then you have some part which is not covered with anything, and that is the membranous urethra, a part of the posterior urethra, the posterior urethra. Okay, and then you have the prostatic urethra, which is present within the prostate, right? This part. So this is the prostatic urethra, this is the membranous urethra, and this is the penile urethra, or you can say the anterior urethra. Now, this anterior urethra is covered with all the cylinders, right?
Yeah.
Yes.
And the prostatic urethra is covered by the prostate gland. But this membranous urethra is not covered by anything, and that means it will be at an increased risk of getting ruptured, right? Of getting a damage.
Yes.
So what happens? You can have two types of injury. One is a saddle injury that happens due to a direct trauma at the penis, and that can lead to a damage of this membranous urethra. And that can lead to a damage of this penile urethra or the anterior urethra. Okay, and I told you have a Buck's fascia, the deep fascia, remember?
Yeah.
If the damage in this Buck's fascia happens, you can have the leakage of this urine into the perineal space. This all space is the perineal space. You can have a leakage of urine in this space as well as within the scrotum. So you will have a swelling of the scrotum because this scrotum is filled with the urine. You will have a swelling in the perineal area. Okay. In the suprapubic region, you will be having a very swelling, and because this area is filled with the urine. In the penis, you will be having a very swelling because this area is also filled with the urine. Patient will also have a history of a direct penile trauma, or you can say the straddle injury could be there. So the blood and urine will accumulate in the scrotum, and the urine will also escape into the perineal space. So presentation will be blood in the urethral meatus will happens. Okay, you will have a bleeding from the urethra from this part. Okay, and it will be a bleeding from there. Scrotal hematoma can also occur, and you will have a bleeding within the perineal space. Is that okay?
Yeah.
Yes.
Now the second type of injury will happens in the posterior urethra, and please note I told you because the prostatic urethra is covered by the prostate gland, the muscular gland. Okay, but the membranous part is not covered by anything. So in the posterior urethral injury, the most commonly damaged structure is the membranous urethra. Okay, and it generally happens because of any pelvic fracture. Okay, so whenever you have a pelvic fracture, as you can see this part, this can directly cause a damage into the membranous urethra, and that can lead to the leakage of the urine within the retropubic space. This is a retropubic space. which is present just below the peritoneum. Okay, you have a peritoneum covering the urinary bladder. I told you, right? In the dome of the bladder, you have the peritoneum. After this
Yes.
peritoneum below, you have the retropubic space, okay, where you have the collection of all this urine. You will be having a high riding prostate, as you can see. The prostate will ride upwards, so it will be a high riding prostate that you will see on the CT MRI of the patient. Okay, the patient will also be having a history of anuria. He cannot micturate, but the bleeding again will be there. If you try, for this cath implant, okay, you cannot have the implementation of this catheter, right?
Yes.
So the catheter implementation will be contraindicated in this case. In that case, you need to directly put the catheter into the urinary bladder by cutting this anterior part, right?
Yeah.
Yes.
You will and you will make a dissection in the suprapubic space. You will cut all these muscles, the rectus abdominis, transversalis muscles, all these fascia will be cutted, and finally you reach the urinary bladder. So with by doing this surgery, you need to vacate the bladder like that. Okay. So a catheter implementation will be this implant will be done in the urinary bladder directly. You cannot put the catheter via normal tract. Okay.
Yes.
So that's about the bladder injury. Let me check if I'm missing anything. Yeah, that's all about it. Now see, you can also have a damage in the bladder also, right? And please note that trauma to the bladder, this bladder directly happens whenever you have any blunt trauma in the suprapubic space, this region. Okay, like by doing any any kind of assault or any kind of a trauma, a blunt trauma mainly. Whenever it happens in the bladder directly, that means in the suprapubic region, at this region, if you have any kind of a blunt trauma, that can directly damage to your urinary bladder. Okay, that is the first thing. Second thing, in the pelvic fracture, the damage to the urinary bladder can also happen because this structure is also lie very close to it, right?
Yeah.
So the bladder can be damaged by two things. One is a direct pelvic fracture that again can damage a mammoth sutra also. And second thing is a blunt trauma to the abdomen. I told you, sorry, in the pelvic, I told you that a blunt trauma in the abdomen can lead to a damage of what organ?
Spleen.
Spleen. Yeah, spleen. And similarly, if you got a blunt trauma in the suprapubic region, you will get a damage of the urinary bladder. And please note, if this bladder is fully filled, okay, and you got a direct trauma here, you will have a rupture of the dome of the bladder. And if this dome of the bladder got ruptured, where you will have a collection of urine?
Into the peritoneal space?
Within the peritoneum, and that's why you will have an intraperitoneal fluid collection. So whenever you see a patient in the clinical vignette describing a patient who is having a collection of urine within the peritoneum, you will always think about a dome of bladder injury. Okay. Now, second thing is the pelvic fracture. If this bladder is got damaged because of a pelvic fracture, then you can have a damage of this anterior wall of the this urinary bladder, right?
Yes.
And if this anterior wall got damaged, then where will you have the accumulation of urine?
Into the retroperitoneal?
In the retropubic space, not the retroperitoneum, which is present in the abdomen. Retropubic space is present in the pelvis. Okay.
Okay.
So again, if you got a pelvic fracture, you will have the retropubic space, which is filled with the urine. Okay, and that happens because of an anterior wall damage. So if they are describing you a patient having a damage in the bladder and the urine is being filled in the retropubic space, that means it happens because of an anterior wall damage. If they describe you a patient having an intraperitoneal fluid collection, that means the damage happens to the dome of the bladder. If they're having any blunt trauma history, 100% it would be an injury to the dome of the bladder. They will ask you where the urine will be collected. If it is a pelvic fracture, then they will ask you where the urine will be collected. It will be in the retropubic space. And if you're having a collection of urine in the peritoneum, can you have a peritonitis because of that?
Yeah.
Yes.
Yes.
Everyone agrees?
Oh, no. When it comes into, it should be sterile, right?
Yeah, the urine is sterile, and that's why you cannot have the peritonitis because of leakage of the urine, okay?
Yes.
So please note, you won't have any peritonitis because of that, because the urine is always sterile.
Right.
Do note that fact also. So that's about the urethral injury and the bladder injury. Any doubt, please ask.
At one point, does the urine become unsterile?
Then you can have a, yeah, and then you can have a UTI, and after
No,
it, you
no.
can have this peritonitis also.
Only after exiting the penis, right? Before.
Yeah.
Okay. Thanks.
And the most common symptom for both the injuries is always a bleeding from the meatus, right? You will see a blood at the urethral meatus. You will suspect a damage of either the anterurethra or the posterior urethra. You will perform the examination. If you see the bulging of the perineal space, or you see the swelling of the scrotum or the penis, you will think about the anterior injury. If you see a high reading prostate, you will think about the posterior urethral injury. Okay, if the patient is having a direct trauma to the penis, that could be a straddle injury. Okay, it will be, of course, the anterior damage. If the patient is having a history of pelvic fracture, that means it will be a case of your posterior urethral injury, or could be a damage in the anterior wall of the urinary bladder also, right? Yeah.
Yes.
So that's about it. Okay, now you have the autonomic innervation of the male sexual responses. For that, you have three things. One is the parasympathetic supply, second is the sympathetic supply, and third is the somatic supply. Okay. Now, whenever the erection is going to happen, first you have the parasympathetic supply. Now, whenever the parasympathetic nervous system got activated, it will transmit the impulses via pelvic splanchnic plexus or the nerves. That means S2, S3, and S4. They will release nitric oxide that will cause the release of cyclic GMP, and that will cause the vasodilation. Okay, and whenever the vasodilation happen, you will have a filling of the corpora, spongiosum or cavernosum.
Cavernosum.
Cavernosum. The cavernosum will fill with the blood, and you will have the penile erection. Okay. Second thing, you have the sympathetic supply, and they will release a norepinephrine. Whenever sympathetic system got activated, the norepinephrine will be released. It will cause the calcium influx, and that will cause the smooth muscle contraction, and that causes the vasoconstriction, and that causes the anti-erectile effects. So sympathetic system for the anti-erectile, parasympathetic system for the erectile effects. Okay. Yeah. Second thing is the emission, and that always happens whenever you got a sympathetic nervous system activation. So for the emission of these pumps for the semen, you will be having an activation of sympathetic nervous system. And please note, the hypogastric plexus is supplying the sympathetic these innervations, okay, which is by the T1 to L2. Okay. Now, after the emission, for the expulsion, it is always dependent upon the somatic supply. It is always voluntarily. Okay, whenever you have a relaxation of the sphincters, okay, that means the activation of the pudendal nerve, you can have an expulsion of the semen. That means ejaculations. Okay. So parasympathetic system for the erection, for the emission, you have the sympathetic nervous system, and for the expulsion, you have the somatic nervous system. Okay.
Okay.
And can anyone tell me why you never have, see, whenever you're ejaculating, you never can have a urine with that, right?
Yes.
Why is that the case?
Because
Whenever you have a micturition, yes.
Urination requires parasympathetic
Yeah.
system.
Yeah, exactly. The urination or the micturition, it requires the parasympathetic nervous system, right? But as you can see, for the emission, the sympathetic nervous system got activated, and as a result, you will never have the micturition with the ejaculation. Okay.
Yes.
And please note, you have the prostatic plexus that lies in a very close association with the prostate glands, and it contains the these splanchnic plexus and the hypogastric plexus. So whenever you got a prostatectomy, okay, for the BPH or for the cancer, okay, these plexus is at a very risk of damage. And whenever you got a damage of this plexus, what you will get is the erectile dysfunction. Okay.
Yes.
Yes.
So note that fact also. For the erectile dysfunction, it will be happens after a prostatectomy, And Stephen will ask you why the patient is having a this erectile dysfunction of the prostatectomy. It is because you have damaged the prostatic plexus of the patient that contains all the parasympathetic as well as the sympathetic supply. Okay.
Yes.
Yeah.
And now you have the sildenafil that again is an inhibitor of the phosphodiesterase 5. And does anyone remember the name of phosphodiesterase 3 inhibitors?
Ambrinon, milrinone.
Yeah, ambrinon and the milrinone, right? And they are acting on the heart. In the heart failure, I give that to the patient, right? Sildenafil,
Yes.
PDE5 inhibitors, and they will cause the decrease in the cyclic GMP breakdown. So increased level of cyclic GMP again, similar to the effects of parasympathetic system. So they can cause the erection also, right? Now you have two types of erections. One is the reflexogenic erection, and second is the psychogenic erection. Okay, the reflexogenic erection occurs whenever you got a genital stimulation. Okay, and you have two again limbs, the afferent limb and the efferent limb. The afferent limb, which is sensory, and the efferent limb, which is motor. Afferent limb, that means sensory inputs are taken up by the pudendal nerve. Okay, it will take the impulses to the sacral center. Okay, that the center for erection is present in the sacrum. Okay, it will take the impulses to the sacrum. From the sacrum, you will have the efferent signals, and that traverse via the inferior hypogastric plexus. Okay.
Okay.
So for the afferent limb, pudendal nerve. For the efferent limb, inferior hypogastric plexus, and that's how you get the erection via a reflexogenic mechanism. Okay, and please note, let me draw this. This is your brain. Okay, and this is a spinal cord. Okay, and this is a penis. I told you, this is a sacral center, for example, right? I told you the first mechanism is a reflexogenic, where the impulses are traveled by the pudendal nerve. It will take the impulses to a sacral center, which is center for the erection, and then the efferent supply is done by the inferior hypogastric plexus. This is a one thing. Okay. Second time can happen with the psychogenic stimulation. Okay, with the visuals maybe. Okay, it is a psychogenic erection, and the signals for that erection is originated within the brain. So whenever you have a damage in the brain, for example, or damage anywhere in this part about this spinal cord, you can have an inhibition of the psychogenic erection, but you can still have the reflexogenic erection, right?
Yeah.
So please note that this reflexogenic erection is independent of the cortical stimulations or these influences. Okay, so whenever you have any damage in the thoracic or a cervical portion of the spinal cord, you can still have the reflexogenic erection, but you will lose the psychogenic erection. Is that okay?
Yes.
Okay. So now the second type, which is the psychogenic erection, it happens, it originates within the brain, happens after the visual or the auditory stimulations or any fantasies. Okay, they are the triggers for the psychogenic erection. Okay, the cortical centers which are present in the brain, they will send the impulses to the sacral erection centers again, and from the sacral erection centers again you will have the inferior hypogastric plexus that is causing the erection. When the lesion happens above the T9, that means in the thoracic or in the cervical portion of the spinal cord, you will have a loss of psychogenic erection, but the reflexogenic erection will be normal. If you're having a damage in the sacral portion of the spinal cord, in that case, you can still have the psychogenic erection, but you won't have the reflexogenic erection after that. Okay. So a sacral spinal cord injury, you can have a normal psychogenic erection, but I have no, inhibition of the reflexogenic erection. In case of the damage before the T9, you will have a loss of psychogenic erection, but the reflexogenic erection will be normal. Okay.
Okay.
So do remember
Right.
this fact also. Yeah.
In case of sacral spine injury, both of the erection will be defective, right?
Actually, it is about different centers. Okay. Two different centers are there. You can still preserve the centers for psychogenic erection. So, you know, they are normal totally whenever you got a sacral injury.
Okay.
Okay. It's actually very much
Okay.
complex thing, not that much simple. It has almost around 50-60 slides. So I got a summary from there. Okay. So it is most simple thing you can get. So just know for the fact that whenever you got a damage in the sacral portion after T9, it will cause a loss of the refluxogenic reaction, but you will again have a normal psychogenic reaction. Above the T9, you can have a loss of psychogenic reaction, but the refluxogenic reaction will be absolutely normal, okay? Are we good?
Okay. Yes.
So do note that fact. Step 1 will ask you, okay, about this refluxogenic, and it will be a patient who is having some kind of a trauma or an accident. Because of that, he's having a damage in the spinal cord that makes him very paralyzed. He's having a paralysis, but still he can have a weak erection, okay, after the stimulations of the genitals, and that happens because of the refluxogenic erection. Step 1 will ask you why the patient is still having the erection. So the answer will be the pudendal nerve and the inferior hypogastric plexus. Step 1 will ask you what is the afferent limb of this erection. So it will be the pudendal nerve. They will ask you what will be the efferent signals. It will be by the inferior hypogastric plexus. Okay.
Okay.
Yeah. So that's everything on.
Sorry,
Yeah.
is the inferior hypogastric plexus is the same the sacral plexus?
Yeah, it contains a sacral plexus also. Yes.
Is it the same one?
See, the sacral plexus is different. Actually, the pelvic branching nerves are different, which are by the S2 and S4. Okay, and this hypogastric plexus, it consists of both the sympathetic as well as the parasympathetic plexus. The hypogastric nerve is a sympathetic nerve. Pelvic branching nerve is a parasympathetic nerve. But this plexus consists both the sympathetic nerve as well as the parasympathetic nerve. Okay.
Okay.
So two different things. Plexus is a different thing, and nerves are different thing, right?
Okay.
Now, any doubt?
No, thank you.
And that's about the bladder injury that we talk about. If you're having any blunt trauma, that will cause a damage of the upper lobe, the dome of the uterus, the urinary bladder, and that can lead to the leakage of the urine within the peritoneum. If you're having any pelvic injury, the pelvic fracture, that can lead to a damage of the anterior bladder, and that will cause a leakage of the urine within the retropubic space. Okay.
Yes.
Now let's discuss the seminiferous tubules. Within the seminiferous tubules, you have some cells. Okay, and you have multiple seminiferous tubules. Let's see, there is a let me draw it again this for you. So I told you you have the testis. Within the testis, you have the septas, right? After the septas, you're having many spaces in the testis, right? These are the spaces that I'm talking about. Within these spaces, you're having all these seminiferous tubules, right? These ducts, right?
Yes.
So if I take the histology of this portion, if I cut it from here, I can see the histology like that. This is the one seminiferous tubule. This is a second seminiferous tubules. In between the seminiferous tubules, you have this space, interstitial space. And that interstitial space consists of a cells, and these cells are known as the Leydig cells. Okay.
Okay.
So in between the seminiferous tubules, you have the Leydig cells. Within the seminiferous tubules, you have the Sertoli cells and the oocytes, or the oogonium, right? These germ cells.
Yes.
So as you can see on this histology, this is one seminiferous tubule. This is the second seminiferous tubule, and so that you have a many seminiferous tubules. In between these, you will be having some interstitial cells, and these are the Leydig cells. In these seminiferous tubules, you have the spermatogonium. Okay, you have the Sertoli cells. As you can see, these lightish cells, these are all the Sertoli cells, and the darker ones, these are the spermatogonias. Okay.
Yes.
So light cells, these are Sertoli cells. The function of these Sertoli cells is to make the blood testis barrier, one thing. Second thing is the nourishment. Third thing is the Mullerian inhibitory hormone, right? Yeah.
Yes.
In the center of this tubule, you're having this lumen. Whenever the sperms got matured, okay, they will enter this lumen, and finally they're transferred to the vas deferens. right?
Yes.
So let's discuss all these cells one by one. First, you have the spermatogonias, okay, and these are the germ cells. They will divide, okay, and when they divide, they will get mature, and then they will produce the primary spermatocyte. The primary spermatocyte will become the secondary spermatocyte, okay. Then you will, and then they will mature to form the spermatozoa, and then the spermatids, and finally the sperms, right? And the lines, the seminiferous tubules, very important. As you can see, they are all present in the periphery part, right? The most periphery cells, right?
Yes.
So the lines, the seminiferous tubules, and they are the germ cells. Then you have the cytosol cells. Function of these cells is multiple functions actually. Okay, cytosol cells increases the estradiol, okay, because it contains one enzyme. And does anyone remember the enzyme name that converts a testosterone into the estradiol?
Aromatase.
Aromatase, right? It contains the aromatase, okay, and with the help of this aromatase, it will convert the testosterone into the estradiol. Second function is to release the Mullerian inhibitory factor that is in the intrauterine life, so that you will have an inhibition of the Mullerian duct. Third thing is to release the inhibin hormone. See, as you can see, you have a hypothalamus, okay, that releases a GnRH. Okay, the GnRH will act on the anterior pituitary to release the LH and the FSH. Function of the LSH is to act on the Leydig cells to release a testosterone. Okay, and the function of the Sertoli cells is to increase the concentration of the testosterone inside the seminiferous tubules. While doing so, okay, the FSH will stimulate the Sertoli cells, and the Sertoli cells again releases the inhibin. So as you can see, in order for the entry of testosterone into the seminiferous tubules, I require the Sertoli cells, right?
Yes.
Because these cells will release the testosterone binding protein that increases the concentration of these the testosterone into the seminiferous tubules. I need this testosterone for the maturation of my sperms.
Yeah.
Okay. Now, if you got an inhibin which is released by Sertoli cells, this inhibin will send a negative feedback to the anterior pituitary that causes the inhibition of the FSH, and as a result, the Sertoli cells won't get activated. They won't release the testosterone binding protein, and you won't get an increased concentration of testosterone, and as a result, no maturation will happen. Right?
Yes.
So the first function is the conversion of testosterone into the estrogen, that is the aromatase. Second is the Mullerian inhibitory hormone or the factor. Third thing is the inhibin, and fourth thing is the testosterone binding protein. These four functions are served by the Sertoli cells. Other than these releasing functions, Sertoli cells has one more function, and that is the blood testis barrier. Okay, they forms the blood testis barrier. As you can see, these are the these are the spermatogonium, which are the germ cells. Okay, and these are all these Sertoli cells. These bluish cells that you are seeing here, these are all the Sertoli cells. These are the nucleus of the Sertoli cells. Okay, the function of these cells is to make the blood testis barrier that will isolate the germ cells from the other cells. So the germ cells, these cells, spermatogonium, they present outside the blood testis barrier, while all other cells, the primary spermatocyte, secondary spermatocyte, spermatids, spermatozoans, sperms, they are all present within the blood testis barrier. Is that okay?
Could you repeat it once, the last thing which you explained?
This is the blood testis barrier, as you can see, right? Outside it, the blood vessels are present. So these Sertoli cells are in a contact with the blood. Oh, sorry. This spermatogonium are in the contact with the blood. But after that, you have the blood testis barrier that will separate all other cells with the blood.
Okay.
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 So no cell. Okay, that means no inflammatory cell, no immune cell, macrophages, lymphocyte, neutrophils. They cannot cross this barrier. They cannot enter into the seminiferous tubules. They cannot attack on any of these cells, but they can still attack the spermatogonias. Okay.
Okay. Yeah.
And that's why I told you, whenever you want to give a chemotherapy to a patient, for example, the leukemias, I told you, the hairy cell leukemia, right? I told you have to specifically give a therapy to the testis again, right? Because of presence of blood testis barrier, right?
Yeah.
Yes.
So please note, these are cytotory cells that will form this blood-testis barrier. And that anyone remember what junctions will take part in the formation of a barrier, the blood barrier?
Tight junctions.
The tight junctions, right? The tight junctions will be present in between these cytotory cells that will prevent the entry of any blood cell, any drug, or any chemotherapeutic agent. Anything cannot pass through this barrier. Okay, these spermatogoniums present outside it, and rest all other cells are present inside it. Okay, and please note, yes.
And that picture again, can you show it, please?
I couldn't understand.
In that picture, can you show it, please?
This picture.
Yes. The empty cell are the circulatory cell, right?
These cells, yeah. These are These are
Yeah,
circular cells, as you can see.
okay.
Let me show
That
this.
side, that other cells that's on the right side, all are spermatogonium cells, or
These
only the
cells.
outer layer?
These cells are the spermatogonias. These
Only the
cells.
outer layer.
These,
Only
yeah.
the outer one.
Yeah, exactly. Only the outer one cells are the spermatogonias.
And the inner two cell and two layers. What are there?
The primary spermatocyte, secondary spermatocyte, spermatids, sperms, right?
Okay, and that's inside of the barrier of the blood testis barrier, right?
Yeah, exactly. As you can see, this is a blood testis barrier that I made. Okay.
Yes.
And as you can see, in the first it also this line. I hope you guys appreciate that this line, right? This line and this line also, right? This is all of one cell. This is all of one cell, the cytosol cell. Okay, this a whole cell, and this is a nucleus of the cytosol cells. On the cytosol cells, you will have the primary these spermatogonias that are present outside the barrier. After the barrier, inside it, you have the primary spermatocytes, secondary spermatocytes, spermatids, and finally the sperms. Okay.
Okay, and the lighting cell, where?
Outside it, outside seminiferous tubule, I told you, interstitial space. See here, this is one seminiferous tubule. Outside it, you have the interstitial space where you have the Leydig cells.
So only two types of cell in the seminiferous tubule, the circulatory one and the spermatogonium.
Yeah, exactly.
Okay, and that inner circle inside is
this.
Yes.
Lumen.
Okay.
Where you have a transport of the sperms. Because it is nothing but a tube. Like these seminiferous tubules are nothing but a tube, so they will have a hollow space inside them, right?
Okay, and the last one, I just got confused. The Sertoli cell will secrete inhibin B?
Cellular cells secreting the inhibin, yes.
Yeah, and what also? Androgen?
See, Mullerian inhibitory factor in the intrauterine life. Okay.
Okay.
They have the aromatase that will convert the testosterone into the estrogen in the males, right?
Okay.
Third thing is basic secretion of the inhibin. Okay, that will inhibit the cytosol cells. Fourth thing is the testosterone binding protein that will help in the concentration of the testosterone inside the seminiferous tubules.
Okay, thank you very, very much.
Okay, so 4 secretory function and 1 is the protective function. Okay, so 4 secretory function and one protection function, that is a blood testis barrier. That is the function circulatory cells perform. Other thing is that these cells are temperature sensitive. Okay, so whenever you have a high temperature, for example, in case of a undescended testis, okay, your testis will remain in the abdomen, where they will expose to a high temperature, and that can lead to the inhibition of the cytosol cells. In that case, they won't release estradiol, they won't release inhibin, they won't release testosterone binding protein, and as a result, patient can have a hypogonadism because of that, right?
Yes.
So the sperm production will be decreased if you got a cryptorchidism, right? And please note, they are the homologous cells of the female granulosa cells, which we will discuss shortly. Don't worry about that. Okay, you have the granulosa, the membrane granulosa cells. Okay, and they are the homologue of these cells. Again, you have the theca cells. Theca externa, theca interna in the females. Okay, the theca interna cells are the homologous of the Leydig cells, and the granulosa cells are the homologous of the Sertoli cells. Okay.
Okay.
So these are all the functions of the Sertoli cells. 4 functions which are secretory one function which is a protective. Okay, one is a temperature sensitive point. Okay, second is the homologous of the female granulosa cells. These 8 points you must remember for the Sertoli cells. Any doubt, please ask.
What's the use of estrogen in males?
You have many uses in this. You have many uses for that.
Like bone development and such things.
The bone development is there, bone growth is there, right?
Okay. Yeah. Thank you.
Give me a second. Yeah, that would be everything. I'm not missing anything, right? Yes, that's all about the Sertoli cells. Second type of cells which are present within, the second type of cells were discussed. Now, outside seminiferous tubules, in between two seminiferous tubules, you have the interstitial space. In that interstitial space, you have the Leydig cells that secrete testosterone in response to the luteinizing hormone or the LH. And please note, these cells are not affected by the temperature, and that means even in a patient having a cryptorchidism, they will have a still release of a normal testosterone. Okay, so a normal secondary sexual characters are there, a normal development is there. It just they cannot produce the sperms if a testis remains in the abdomen. Okay.
Yeah.
So remember this fact also. The Leydig cells, they are not temperature sensitive. Only Sertoli cells are temperature sensitive. So you will have a normal testosterone production, but a decreased sperm production because of the cryptorchidism. Please note that they are the homologous of or the analogs of the theca interna cells. Okay, they are present in the interstitium. So what happens is whenever you have an activation of the hypothalamus, this hypothalamus will release the GnRH that will cause the activation of the anterior pituitary to release the LH and FSH. The function of the LH is to act on the Leydig cells to release the testosterone. The function of the FSH is to act on the Sertoli cells and cause the release of the testosterone binding protein, this aromatase, and the release of inhibin also, right? When the inhibin is released, whenever you got a sufficient activation of the Sertoli cells, okay, then you will have a release of inhibin. And when the concentration of the inhibin increased, it will cause, please note, it will only cause the inhibition of FSH. It will act on the anterior pituitary and just inhibit the cells which are releasing the FSH. When the amount of testosterone is increased, they will give a negative feedback both to the anterior pituitary as well as to the hypothalamus. So whenever you have a high testosterone level, it will suppress both the LH and as well as the FSH by inhibiting the hypothalamus. Whenever you have a high amount of inhibin B, it will only inhibit the FSH. Is that okay?
Yes.
Okay, so whenever you have a testosterone, it will inhibit both the pituitary as well as hypothalamus. But whenever you have a this inhibin B, it will only inhibit the pituitary, only the FSH releasing cells. So whenever you have a high testosterone, you will always have a low level of GnRH, low level of LH, low level of FSH. But whenever you have a high inhibin B, you only have a low level of FSH. Okay.
Yes.
So that's it. The LH gives a negative feedback to pituitary hypothalamus. FSH via inhibin B gives a negative feedback to the pituitary only. That means decreasing the FSH levels only. So any doubt, please ask.
No, thank you.
No, thank you.
So we are done with the anatomy. And now we are going to start the physiology. So let's take a short break again and discuss the physiology, okay?
Yes.
Okay.
Thank you.
Okay, so you got a patient who is having a unilateral archectomy recently. Okay, so after this unilateral archectomy, what you can expect in this patient? What about the testosterone level? What about the libido? What about the erectile functions? What about the spermatogenesis? What about the sperm count? If it decreased, then would it be severe, moderate, or a very less decrease? Okay, so think about it and write the answer in the chat box. Please try to attempt everyone so that we can discuss all of these things that will happen. Answer for every one of them, right? 1, 2, 3, 4, 5. Okay, so let's discuss what will happen. You got a patient in which you remove one testis. After that testis is removed, does the Leydig cells, Sertoli cells? I got one answer also. Yeah. Okay, so when you remove one testis from the patient, you have removed the Sertoli cells, Leydig cells, and the spermatogonium from that, right?
Yeah.
Now, when these cells are removed, as soon as you remove the Leydig cells, the testosterone count will decrease, will drop, right?
Yes.
When the testosterone level were dropped, what you can have to the this negative feedback?
Reduced.
The negative feedback will be reduced, and as a result, you will have an upregulation of LH and FSH.
Yes.
And whenever you have an upregulation of FSH and LSH, the LSH from the remaining testes, you will have an increased production of the testosterone from Leydig cells.
Okay.
So what happens is that testosterone production from the remaining testes will be increased, and what you will get a slightly reduced or a normal level of testosterone, right?
Yes.
Now, because that testosterone levels are normal, you will have a normal libido.
Okay.
The erectile function will be normal, right?
Yes.
Oh, what does this erectile function depend on?
The testosterone level, it requires testosterone for that. The dihydrotestosterone, remember? The DST is not there, then you won't have the erection, right?
Okay. Yeah. Okay.
Hypogonadism, if you guys remember, right? So testosterone level are responsible for the libido and for the erectile function. If it is not there, you will get the erectile dysfunction because of that. Other thing is the spermatogenesis. What about that? Now, because the LH level is increased, you are having a rise in the level of testosterone from the remaining testes. Second thing, the FSH levels are also increased because now Sertoli cells are not there for the inhibition, right?
Yes.
Yes.
Inhibin B levels are decreased, so FSH levels are increased. These FSH will stimulate the Sertoli cells of the remaining testes to secrete more testosterone binding protein,
Yes.
and that
Yes.
will lead to an increase in the spermatogenesis from the remaining testes.
Yes.
So the spermatogenesis will be increased.
Yes.
Now, what happens is you have a limited the seminiferous tubules only, like, right? You have removed one testis, you have only 50% of the seminiferous tubules working, right?
Yes.
Yes.
So no matter how much you increase your spermatogenesis, it can never secrete all these sperms to a normal level again.
Yes.
So you will have a decrease in the sperm count. Okay.
Okay. Yes.
And that can even cause the infertility to the patient. So with the archaectomy, the testosterone levels are absolutely normal or slightly reduced, not significantly reduced. Libido will be normal, erectile function will be normal, spermatogenesis will be increased, and you will have a decrease in the sperm count that can even lead to the infertility. Is that okay?
So even the this spermatogenesis will increase, like
Yes.
compulsory.
Yes.
Still, the sperm count, of course,
See, let us
because
suppose.
anatomical. So even though spermatogenesis will increase, it cannot be as equal as the bilateral.
Yeah,
Case,
let me explain that. See,
yeah.
initially you have, let's suppose, 100 these tubules, 100 tubules, right? And these 100 tubules were producing 100 sperms, for example. You have removed 50 tubules by removing one testis, right?
Yeah.
Now you have only the 50 tubules functioning. You're increasing the and you're increasing the Sertoli cells. You're increasing testosterone, so that will stimulate the remaining 50 these tubules to secrete 70 or 18, for example, these sperms, right? But it's still not 100. It's still less than 100, right?
Yeah.
And this is a significant number, so you will have a significant reduce in the sperm count. Okay.
So is that the sperm count is lower limit to fertilize the?
Yeah, exactly. It can be at a lower limit, so it can lead to the infertility of the patient also.
Okay. Thank you.
Okay, because you need almost I don't exactly remember what number of sperms required
Yeah,
for the
I also
fertilization.
don't remember. Yeah.
It's in the millions. I don't remember exactly, but you will have a very low count of the sperms because of that. Almost 60% only, but you require almost 80% or 90% of the sperm to be functional in order to get a fertilization, right? So because of this reduced count, you cannot have the fertilization. You will become infertile. Spermatogenesis, someone is asking. Okay, so what happens is whenever you have a loss of these tubules from one testis, from the remaining tubules, the level of inhibin will drop, and as a result, you will have an upregulation of FSH. The level of testosterone will be dropped initially, so that you will have an upregulation of LH also. So the increase in the LH will maintain the normal testosterone level. So you will have a normal libido, normal erectile function. From the remaining of the Sertoli cells, you will have a release of this the testosterone binding protein that will increase the concentration of testosterone inside the tubules. As a result, the spermatogenesis will also increase. Because of this increase in the spermatogenesis, they will try to compensate somehow the loss of one testis, but it is never sufficient to cause a full compensation. The number will drop, the sperm count will drop, but the spermatogenesis will be increased in the remaining testis. Okay. So that will happen whenever you got a unilateral archaectomy. Testosterone level will be normal, libido normal, erectile function normal, spermatogenesis increased, and sperm count will be decreased. Because no matter how many sperms you made, you can still would never fulfill the normal levels back again. Right? And out
Just
us.
the first step we lost the Sertoli cell and the Leiding cell from the removed one.
Yeah. Yes.
Yeah, that will lose or affect the negative feedback inhibition on the both
Yeah.
LH and FSH and GnRH.
Yes. And then again, you will have a negative feedback. Negative feedback will now increase the GnRH, LH, and FSH.
Okay, and on the remaining one that will try
Yes.
to compensate will release testosterone.
Yes.
From the Leiding cell more. That's it. So libido and
Yes.
erectile will be okay. Okay.
Yeah. Okay. See, this negative feedback doesn't mean it always reduces these levels. Negative feedback means whenever you have a high level of testosterone or the inhibin, it will reduce the levels of LSFSH. And whenever you have a low level of testosterone and this inhibin, it will increase the level of this LH and FSH. That's what this negative regulation means, right? So because in this case, you're having a low level of testosterone and this the inhibition inhibitor at a very initial stage, it will cause the increase in the release of this LH and FSH. So it will increase the production of testosterone and this inhibin and all other things from the cytosol cells in the remaining testes. So that will cause an increase in this spermatogenesis for the compensation, of course, right?
Okay, the main cause for all of that is the loss of negative feedback inhibition.
Yeah, exactly.
Okay.
Actually, increase in the feedback, negative feedback. And because of this increase in the negative feedback, because the levels are dropping, this negative feedback now increase the level of GnRH, FSH, and LH.
Okay.
Okay.
Yes.
Any more doubt? Please ask.
No, thank you.
So now let's move forward. Let's discuss the reproductive physiology. And first we have is the spermatogenesis. I told you outside the tight junction, that means outside the blood testis barrier, you have the spermatogonium. Spermatogonium, just like any other body cells, they are always diploid, 2N, 2C. Okay. When they're about to divide, they will first become 2 and 4C. That means two different site of chromosome with 4 copies. That means two different type of copies. Is that okay? Let us, if I want to draw that for you, if this is my chromosome, this is second chromosome, okay? This will be the C1A, for example. This again is a C1A, okay? This is the C2A. You have a C1B, for example, a B type, okay? And this is again a C1B. So as you can see, two different set of chromosomes, okay? C1A and C1B, and two copies of each set, AA and BB, right? So a total of 4 chromosomes, that means a 4C, and there are two different sets, 1A and 1B, right?
Yeah.
And I hope you guys remember about the concept of homologous chromosomes and the sister chromatids.
Yes.
So this N basically denotes the homologous chromosomes, and this C denotes the sister chromatids. Okay, so a total of 4 sister chromatids are present, and a total of 2 homologous chromosomes are present, right?
Yeah.
So when the cell divides, it again becomes 1N and 2C, because at a very initial stage, you will have a division of or a separation of homologous chromosomes, right?
Right.
So when the homologous chromosomes separate, you will just left with the sister chromatids in each cell. So 2 sister chromatids in each cell with a 1 homologous chromosome, 1 and 2C will be seen. For example, if you have an X chromosome, then in this cell, you will only have the 2 copies of X chromosome. If you have a Y chromosome, then in this cell, you will have 2 copies of Y chromosome. That means 2 sister chromatids for the Y chromosome, right? Then again, you will get a second, and after this, this thing, you will become, this gonium will enter into the tight junction. From a tight junction, it will enter into some these tubules, and within these tubules, they will become the primary spermatocytes, which are diploid, 2 and 4C. Okay, then they become the secondary spermatocytes, which are haploid, 1 and 2C. Okay, then the meiosis 2 will occur, where you have a separation of sister chromatids, and after separation of sister chromatids, you will become 1N and 1C, only one set of chromosome with 1 copy, 1 sister chromatids, right? You will have a separation and you become the spermatids. So spermatogonium, spermatocytes, primary and secondary, and then the spermatids. Finally, you have the maturation process, which is the spermiogenesis, and that happens in the epididymis part. And in the epididymis, they become the matured spermatozoa, and finally they become the sperms. In the spermatozoa, on the tip of the head, you have the head, you have the body or the middle piece, and then you have the tail. Okay, in the head of the this sperms, you have the acrosomes at the very tip, which basically nothing but just a Golgi body. And I hope you guys remember the function of Golgi bodies, the secretion of every protein from the cell, right?
Yes.
So basically, they secrete some enzymes that will cause, the hydrolysis of this layer of the oocyte, so that the fusion of the male and female gametes can happen. Okay, they have the enzymes in them. Then the head, and it contains the nucleus. This nucleus will contain all the chromosomes that will be transferred to the cell for the fusion. It has the mitochondria that is present in this middle piece that provides the energy. Finally, it held a tail, and the function of tail is to provide the mobility. And does anyone remember one disorder where you have the loss of mobility?
Cartagenous.
The cartagenous syndrome. And what is the defect in that part?
Dynein arm.
Dynein arm defect. Yes. This tail part contains a dynein arm that has the ATPase. Okay, so energy from the mitochondria will be utilized by this tail for the movement only with the help of ATPase. If it is not present, you will get the immobile sperm, so you will get the infertilization. Okay.
Yes.
So the tail mobility will be impaired in the cartagenous syndrome. Okay, and the tail mobility is absolutely normal, but you have a loss of vas deferens in the cystic fibrosis. So in both the disorders, you will get a infertility, but the reasons of the infertility is different, right? So that's about the spermatogenesis. The process of conversion of this spermatogonium into the spermatid is known as a spermatogenesis, and the conversion of spermatid into the spermatozoon, okay, that is known as a spermiogenesis. Okay.
Okay.
Any doubt, please ask.
From which stage to which stage is called a spermatogenesis?
Up to the formation of spermatids.
Okay. Okay.
Okay, from spermatogonium to the spermatids, that means the sides and the tids, this will be the spermatogenesis. Okay, and finally from spermatid to the spermatogoniums, again, there is the spermatozoons, you will call it as spermiogenesis. Okay.
Okay, yeah. Thank you.
Important thing to remember is these ploidies, the 2 and 4C, 1 and 2C, they will ask you. So just know 2N representing a homologous chromosomes in a cell, and 4C representing the number of sister chromatids in a cell. In a normal cell, I have 2 homologous chromosomes with 2 copies, a total of 2 copies, that means 2 sister chromatids. Okay, in a division cell, a cell which is dividing, I will have 2 homologous chromosomes, so a total of 4 sister chromatids, which are about to divide. Once first you will have a division of or you can say a separation of homologous chromosome, and then you will have a separation of sister chromatids, right?
Yes.
So we have discussed all the male part, and now let's discuss the female part. In the female, I told you, just like the male where you have the Leydig cells and the Sertoli cells, in the female you have the theca cells and the gangliosa cells. So just like the LH is acting on the Leydig cells in the male, the LH is acting on the theca cells in the female, and in the theca cells it is forming the endostrandions. Okay. Now this endostrandion, just like the testosterone analogs, they will diffuse into the gangliosa cells, and in the gangliosa cells they will be converted into the estrogen via the action of enzyme aromatase. I told you that these gangliosa cells are analogous of the Sertoli cells, right?
Yes.
So they contains the aromatase that will convert all this endostrandion into the estrogen, and finally the estrogen will be exit from the ovaries, enter into the bloodstream, and causing its effects. As you can see, this is a mature follicle, a graphene follicle, you can say. This graphene follicles has layers. The outer layer is known as the theca cells. It has 2 layers again, the theca externa, which provides a protection to this follicle, and then the theca interna cell, which contains this function. In the inner layer, you have the gangliosa cells, and the function of gangliosa cells is to release the estrogen. And at a very central part of this follicle, you have the oocyte here. Okay. Whenever this follicle rupture, whenever this graphene follicle rupture, it will release the oocyte that will be collected by the fallopian tubes for the fertilization. Okay.
Yeah.
So this is the structure of a graphene follicle. Now let's discuss what the estrogen do in our body. Okay, so please note it has an action on the breast, It has the action on the ovary. It has the action on the uterus. It has an action on the binding proteins. It has action on the lipids, bones, and the prolactin. Different forms of the estrogen exist. You have the estradiol, which is the most common form. From the placenta in the intrauterine life, you have the release of estriol. Okay, and from the this adipose tissue, you have the release of estrione, because I told you that the adipose tissue, these fat cells, they also contain the aromatase enzyme, right? And that's why in the fatty patient, an obese patient, you can have a PCOS because of that.
Yes.
So the potency, if we talk about, estradiol is the most potent, estrione is the second most potent, and the least potent one is the estriol. If we talk about the concentration, then in the intrauterine life, this estriol is present in the maximum concentration. In the normal patient, in the adult, you will have the estradiol in the maximum concentration. After the menopause, the estrione will be in the maximum concentration, because because you guys already know, after the menopause, you don't have the ovary functionable, right?
Yes.
So now what's going to happen after the menopause? You have the this cortex and neocortex, right, where you have the what's his name? The zona reticularis, right? You have the zona reticularis that will secrete the endostrandione. I told you. If you go back to this endocrine part, we have discussed all these processes, right?
Yes.
So what happens is in the adrenal cortex, you have these cells, the zona reticularis, and these cells will release the endostrandione in the blood. From the blood, this endostrandione will reaches to the peripheral tissues like the adipose tissue, and in the adipose tissue, this estrogen will be converted into the estrione. So the estrione will be the major estrogen in a postmenopausal female. In an adult female, premenopausal, it will be the estradiol after the birth. In the intrauterine life, the estriol will be present in the maximum concentration. Okay. Okay.
Yes.
Now, the development of the breast is done by the estrogen. It happens after the puberty whenever the levels of the estrogen increases. So it causes development of the breast. It causes the development of the genitals in the female in the intrauterine life we have discussed, right?
Yeah.
So genitals in the female, they will be developed by the estrogen. Estrogen will be acting on the ovary, causing the maturation of all these follicles, right?
Yes.
The growth of follicles in the uterus. Okay, for every cycle, you will have a hypertrophy in the uterus, right?
Yes.
And that hypertrophy as well as hyperplasia, both things happen. And this hyperplasia as well as hypertrophy in each cycle, it is done by the estrogen only. Okay. When you have the menstruation, you will have a sudden drop in the level of estrogen. Now this estrogen cannot maintain the uterus, and as a result, you will have a shedding of the lining of this uterus, right? And that causes the menstruation, right? So the function of estrogen is to maintain the breast, is to maintain the ovary, causing the maturation of follicles, and to maintain the lining of the uterus. I told you, whenever you have a high level of estrogen, it will always increases the level of all the binding proteins. Okay, the iron binding protein, the copper binding protein, remember the testosterone binding protein,
Yes.
and the thyroid binding protein also, right? So all of the level of binding proteins will be increased. And I told you, only the free hormones can give a negative feedback.
Right.
So because our level of free hormones are now decreasing, they will give a negative feedback that will increase the concentration of these hormones, right? The iron will be increased, the thyroid will be increased, the testosterone will be increased. So as you can see, because the levels are increasing, the total level will be increased. The free level will be either normal or either decreased slightly, okay? And the binding level will be increased, okay?
Yeah.
So total level always increasing, free level either decreasing or either normal. That's what we see whenever you have a high level of estrogen or whenever you have a high level of binding proteins. Okay.
Yes.
Now, other thing, the action on the bones. We already know that it increases the amount of OPG, the osteoprogesterone, that will cause the activation of osteoblast. So it will take part in the bone growth. It will decrease the risk of osteoporosis. And the final action is on the prolactin. And in the brain, it increases the level of prolactin. That again happens in the pregnancy. In the pregnancy, you have a high level of estrogen that will cause inhibition of the dopamine, and as a result, you will have a more production of the prolactin. But I told you, in pregnancy, you will have a blockage of the receptors by the progesterone, right? So although in the pregnancy you are having a high level of prolactin, you still cannot uh, have this formation of milk because of inhibition of the receptors by the progesterone, right?
Yes.
So the development of genitals, breast, female fat distribution is done by the estrogen, that is the action on the lipids. It causes a redistribution of the fats. Growth of the follicles will be done in the ovary. Endometrial proliferation every cycle. It happens because of the presence of estrogen. Okay, upregulation of estrogen happens. Okay, it initially gives a negative feedback to the LHFSH, but after 14 days, after 10 or 12 days, it start giving a positive feedback to the pituitary and hypothalamus to increase the LH and FSH, and that again can lead to the oogenesis, right?
Yeah.
We will discuss the cycle later. Don't worry, in the next page we'll discuss the cycle. So just know, initially before 12 days, this estrogen will give a negative feedback to the pituitary and hypothalamus so that the level of FSH and LH will be low. After 12 days, it suddenly start giving a positive feedback to the pituitary and hypothalamus, and that causes a sudden surge in the level of LH and FSH, and that causes the ovulation. Okay.
Yes.
Again, the cells in the brain, okay, the lactotropes, it will cause a hyperplasia of the lactotropes. The level of prolactin will be increased whenever you have a high level of estrogen. The transport proteins will be increased, like the transferrin, the testicular binding, the thyroid binding these globulins. Steroid hormone binding globulins will be increased. Please note the level of HDL will be increased because of estrogen, and the level of LDL will be decreased after the release of estrogen. So whenever you have a menopause, in the menopause in a very old patient, they can have a low level of LDH, the HDL, and a high level of LDL will be there. Is that okay?
Okay.
So that's about the function of estrogen. Any doubt, please ask.
Yes, I have a question.
Yes.
Is a theca cell and the granulosa cell is a own cell for each oocyte, or it's ovarian stroma cells?
Repeat it again. The thicker cells and the granular cells. After that,
Is the theca cell and the granulosa cell are own cell for each follicle and each oocyte, or they are ovarian stroma cells?
no. For each follicle, you have a different thicker cells and the granular cells represented
Okay,
in the follicles. Yeah.
separated from the ovarian stroma.
Yeah. Exactly.
Okay.
And if you guys move forward, we'll and in later part of this chapter we will discuss about the cysts. Okay. And on the cyst, I will tell you that whenever you have a cyst, like in case of a PCOS, okay, you will be having a cyst that is releasing all the estrogen. Okay, because in the cyst you will have this, the cyst of these follicles. Okay, what happens is whenever this graphene follicle matured but does not get ruptured for somehow, it will become a cyst. Okay, and whenever the cyst formation occur, it will cause an increased release of all this estrogen from that, and that again is a reason of PCOS. Okay, you have two
Yes.
types of cyst. One is a follicular cyst, and second is thicker lutein cyst. Okay,
Yeah.
so whenever you have a follicular cyst, it because of an unruptured graphene follicle, and that can lead to an increased release of estrogen, and that is again why you will see in the case of a PCOS, you're again having a high level of estrogens, right?
Okay.
And you're also having a multiple cysts in the ovary. That cysts are also the follicular cysts. Okay, and all of these follicular cysts, they will be releasing all this estrogen from that follicle, because in the follicle you're having a granular cells that are releasing all the estrogens, right?
Yes.
So do remember that fact also. For the ovarian cyst, you have the follicular cyst, and this unruptured graphene follicle, it become a cyst that will again have the granular cells that will release all the estrogen, and you can again have a multiple cyst because of that. So that again causes the PCOS. Okay.
Okay, so that and estrogen will affect will be in the circulation, so affected the other oocyte.
Yeah, exactly. Because in order to get a rupture, in order to get an ovulation, you need a sudden surge in the level of LH, FSN, and estrogen, right? But
Yes.
because you're already having a very high level of estrogens, you're already having a high level of LH. So no surge happen. If no surge happen, this matured follicle will never rupture. It will become cyst again. And so on, this
Okay.
cycle repeats. You will get a multi-cysts in the ovary, multiple cysts in the ovary, right? That causes a PCOS.
Thanks.
So that's about the estrogen. Any doubt, please ask.
No, thank you.
Second, you have the progesterone. Okay, source of the progesterone in the first trimester will be the corpus luteum. I told you you have the beta HCG released by the placenta from the syncyte trophoblast, and that causes the stimulation of corpus luteum to secrete the progesterone. After first trimester, this function of release of progesterone will be taken up by the placenta itself, and now the placenta is releasing all the progesterone. So now the placenta does not require beta HCG, right?
Yes.
So as a result, after the first trimester, you will have a sudden drop in the level of beta HCG because the placenta stops secreting it. Is that okay?
Yes.
Other sources are the cortex, okay, the zona reticularis, cells, testes are also secreting the progesterone. Okay, function is in the luteal phase. Okay, which we'll discuss later. It will prepare the eggs for the implantation and for the fertilization. Okay, it will stimulate the endometrial layer of your uterus, okay, to increase the secretion of them. Okay, and it will also form a spiral artery in the endometrium. So if you do the biopsy of the patient at that time after the ovulation, where you have this level of a very high level of this progesterone, if you do the biopsy of the endometrium, what you will see are the tortuous glands and the spiral arteries, and a thickened, or you can say, edematous endometrium will be seen. Okay, why edematous and this endometrium? Because it increases the secretion of the endometrium, so that will make the endometrium very edematous. So edematous endometrium, spiral arteries, and tortuous glands, it all because of the progesterone formation. Okay,
Yes.
other thing is it will cause a thick production of the cervical mucus, so it will inhibit the entry of the sperms in the uterus. So, and that is the other reason why we give the patient the combined OCPs, right? As a contraceptive pills, we give the patient combined OCPs, which contains the progesterone as well as the estrogen. Why progesterone? First thing, because it blocks the receptors of the estrogen. Okay, so that you cannot have the hyperplasia and you cannot have the cancer. Second thing, it blocks the entry of the sperms into the uterus. Okay, it prevents the endometrial hyperplasia. That is again the reason why we give the patient combined OCPs. It also increases the body temperature. The level of progesterone suddenly increases after the ovulation, because after the ovulation, this Graafian follicle will be converted into the corpus luteum, and the level of luteinizing hormones are very much high at that time, and this luteinizing hormone will stimulate the corpus luteum to cause to secrete the progesterone, right?
Yes.
No, should I repeat it again?
Yes.
Yes, please.
Yes, please. Thank you.
What happens is, before the ovulation, you have the follicles which is maturing under the influence of estrogen, right?
Yes.
When this follicle matured and you have a sudden surge in the level of LH-FSH, which we'll discuss later, don't worry, you will have a rupture of this follicle and the oocyte is released.
Yes.
You have the ovulation. Now, after this ruptured follicle, under the influence of luteinizing hormone, it is converted into the corpus luteum after 14th day, okay, when the ovulation occurred.
Yes.
Now, under the influence of LH again, this corpus luteum will secrete this progesterone. Like I told you, the corpus luteum, right? Now, if the pregnancy occurs, okay, because what happens is after 25 days, I think, I'm not sure about it, but after 25 days, what happens is the level of this LH is suddenly start dropping. Okay, and as a result, when the level of LH is dropping, you will have a drop in the level of progesterone also.
Yes.
Like I told you, the maintenance of the layer of the endometrium dependent upon the progesterone. It causes all the
Yes.
secretions and other things. A sudden drop in the level of LH will cause a sudden drop in the progesterone, and that causes the menstrual flow, the bleeding, right?
Yes.
If the pregnancy occurs, the function of LH will be took over by the beta HCG.
Yes.
Because if if this fertilization occur at the 14th day, then after 6th day, that means around 20th day, the beta
Yes.
HCG will be present,
Yes.
right? And that beta HCG will stimulate the corpus luteum because it acts as a luteinizing hormone to cause the release of progesterone, and that will maintain the corpus luteum, release of progesterone, and that will maintain the endometrium layer, right?
Yes.
So the level of progesterone, it suddenly rises soon after the ovulation. Okay, and when the progesterone levels are rising, it always increases the body temperature. So whenever you have an increase in the body temperature, it means you are in the post-luteal phase. You are in the luteal phase. That means the ovulation has been occurred. Okay,
Yes.
it is again a sign for the ovulation. Very important. It decreases it decreases the estrogen receptor expression, and as a result, it will prevent the endometrial hyperplasia again. Okay, it will give some negative feedback to the LH and FSH. So after 14th day, the level of LH and FSH will keep on dropping. Okay, after some time, when the levels are significantly dropped, you will have a loss of stimulation of the corpus luteum, and that causes a loss of progesterone also. That causes the menstrual flow, right?
Yes.
Now, at the
Thank you.
time of pregnancy, it will help in maintaining of the pregnancy, first thing. Okay, and whenever the progesterone is there, it will decrease the mobility of every smooth muscle that you know. The GI smooth muscles, the gallbladder, sphincters, okay, this myometrium, every smooth muscle that you know, it will decrease the uh, the contraction of these smooth muscles, right? And because
Yes.
the contraction of these smooth muscles are decreasing, it will decrease the myometrial excitability that will help containing the pregnancy, right? Because
Yes.
of the myometrium contract, that can lead to the miscarriage also, right?
Yes.
So that's why this
Yes.
progesterone is very much important for the pregnancy. Similarly, because it is decreasing the sphincter's tone also, it will cause the GERD in the pregnancy is caused because of progesterone,
Yes.
right? You can have a
Yes.
diarrhea because of, and you can have a constipation because of this progesterone because it causes a relaxation of smooth muscles in the GI tract.
Yes.
Because of relaxation of smooth muscles in the gallbladder, you can have a stones because of this progesterone again in the pregnancy, right?
Yes.
So remember all these things. Progesterone will always decreases the tone of smooth muscles in every part of your body. Okay. Again, it will cause the inhibition of the receptors of the progesterone. So basically, even if the prolactin is present, it will have a decreased action on the breast because of presence of progesterone. Soon after the birth, because what happens is in the pregnancy, you have the estrogen that causes the positive feedback and release of prolactin, right? You will have a very high level of prolactin in the pregnancy. Is that okay? Yes. But
Yes.
now, because even if the prolactin is present, you will have the progesterone blocking the receptors of the progesterone, this prolactin, and as a result, even due, even after the presence of this high level this prolactin, it cannot act on the breast. Soon after the birth, when the level of progesterone drops because of the loss of the placenta, you will have the loss of receptor blockage by this progesterone, and as a result, you will have a sudden lactation. Okay.
Yes.
The progesterone will drop immediately after delivery.
Repeat it again, please.
Progesterone level will drop immediately after delivery.
Yeah, exactly. It will diminish. The level will drop immediately after the birth. Yes.
So
Okay.
so estrogen can affect prolactin.
See,
Prolactin can win.
estrogen has already done its part.
Yeah. Okay.
The function
Yes,
of
yes,
estrogen
yes.
is to release the prolactin, right? The function is done.
Yes, yes.
You have now a high
Prolactin is
level of
there.
yeah.
Yes.
This it is always
Okay.
there, right? But
Yes,
but it
yes. It's
yeah.
now can function after birth.
Yeah, exactly. What happens is whenever the prolactin got activated, it will give a negative feedback to the LH and FSH. So when the prolactin is there, initially because the progesterone receptors initially because the progesterone is blocking the receptors of the prolactin, it cannot give any negative feedback. It cannot act on the breast. As soon as the levels are dropping, Now this prolactin can give a negative feedback to the pituitary and hypothalamus, right?
Yes.
And as a result, it will decrease the level of LH and FSH. And as a result, whenever you have a high prolactin levels, it will always decreases the level of estrogen. And that's why in the hyperprolactinemia, you can have a osteoporosis also, right?
Yes. Also,
But now, yeah.
well, it also will have amenorrhea because of negative
Yeah.
feedback and
Yeah, because of this
loss of
negative feedback and
loss
because of loss of estrogen,
yes.
you can also have the amenorrhea,
Yeah. Yes.
right? So please remember
Yes.
this concept. In the initial part, you have the prolactin, estrogen, and progesterone, dono, all of these things, and that will be blocking the receptors of the prolactin. So high level of prolactin, high level of estrogen, high level of progesterone. Soon after the birth, the level of progesterone will drop, and this prolactin can now access its receptors, and as a result, it will cause a drop in the level of estrogen, LS, and FSH also. It can act on the breast, causing the lactation. Okay.
Yes.
So that's everything about the progesterone. Any doubt on this page, please ask.
The rise in body temperature is before ovulations or like after ovulations, the temperature falls, right? With the progesterone.
When you can have a high level of progesterone? Before ovulation or after ovulation?
So it
After?
will be after ovulation, right?
Exactly. And when you can have a high body temperature? With progesterone or without progesterone?
It is showing here with the progesterone, right?
Exactly. So whenever you have a high progesterone, then only you can have a high body temperature, right? And that happens after the ovulation, right?
Yes.
So only after ovulation, when you have a corpus luteum, when you have a progesterone, you can have a high body temperature. And this increase in the body temperature is a sign of ovulation.
So when it increased, the ovulations started, right?
Ovulation has
When
been
it starts,
finished.
yeah, finished.
Yeah, and it is a sign that you have the graphene follicles, right? Sorry,
Ah,
it
little,
is a sign that you have the corpus luteum in the body, right?
little, yes.
And that only happens whenever you have a rupture of this follicle. So the ovulation has already occurred. Okay, the corpus luteum has been formed, and now you're having a high level of progesterone that is causing a high body temperature.
Okay, so corpus luteum start working and this all. Okay, got it. Thank
Yeah,
you.
exactly.
Thank you.
Any more doubt?
No, thank you.
Okay, so
No,
that
thank
would be everything on this page. So let's find up the session for now. Okay.
Okay.
Thank you.
Thank you so much.
Thank you so much,
Thank you.
everyone.
Thank you very much.
Thank you so much.